Good evening, everyone. I am Dr. Mayur Agrawal from Hormone India, Bhopal. On behalf of organizing team, I welcome you all on this third day. Day one was our pituitary day. Day two was adrenal. And today we have slight change. Today we have Hall A as reproductive endocrinology and Hall B as pediatric endocrinology. It's not advanced and basic as we did in other days. So without wasting much time, I welcome Dr. Shekhar Reddy. He'll be introducing our first speaker. It is already 5:03. So Shekhar, you can take over.
Thank you, Mayur. Good evening, everyone. Good evening, Srinagesh.
Good evening.
And first, let me introduce the speaker for today. He will be speaking on management of hyperactive sexual desire in men and women. Tech team, sir, CV, please. Sir is currently a consultant endocrinologist at Srinagesh Diabetes, Thyroid and Endocrine Clinic. As we all know, Sir is academically very much oriented and he has many gold medals to his name. And is also a best orator at Thai Summit for his presentation on early insulin initiation. And he is a fellow of prestigious ISPAD and ESP Association. And he is also a AR Seth Award winner. And he has 25 peer-reviewed publications and also 15 textbook chapters. Over to you, sir.
Thanks, Shekhar, for the introduction. And at the outset, good evening, respected audience. I'd like to thank the organizers of Hormone India conference for giving me an opportunity to be a part of this meeting. And I should thank them and also curse them for giving me a topic like a hyperactive sexual desire. This is something which we generally don't know in clinical practice, but it makes the presentation all the more interesting. I'm sharing my screen now. Can you see my screen, please?
Yes.
Yeah. For the next 20-25 minutes, I'll be speaking about management of hyperactive sexual desire in men and women. This is a huge topic, and it's good that they have thought of this topic as the opener in reproductive endocrinology, because the first thing which you need in reproduction is desire. Only once you have desire, then does the process of reproduction set in. This is often not discussed majorly in clinical meetings. This has multiple components. This has a psychological component. This has a hormone component. This has a urological component. It is a multidisciplinary topic, but the amount of attention which is actually paid to it and which causes a huge amount of distress to patients who have this problem is usually underestimated in the general practice. This is how my talk is going to be. I'm going to give you a brief definition. There are multiple definitions. In fact, the DSM-4 gave us a definition. Then we had a new modification of the definition in DSM-5. But subsequently, people thought that the definition in DSM-5 was actually inadequate, and many people have actually gone ahead and gone with the DSM-4 classification. Focus on the women part, etiology, assessment, management, then men. By default, I'll be giving a lot more focus to the women part in this topic because hyperactive sexual desire, decreased libido, and erectile dysfunction in men is often very well discussed in meetings, and I'm sure all of you are very familiar. It is the female part which is often neglected, and I'm going to focus a major bulk of my talk on the female part because I want to give more attention to one which is often ignored. According to the DSM-4 manual, which was published in 94 and which holds good even today after 30 years, the basic definition of this disorder is deficiency or absence of sexual fantasies and desire for sexual activity that causes marked distress or interpersonal difficulty. The prevalence in women is grossly underestimated in the general population. Approximately 40% of all women worldwide at some point of time or the other in their life are presented with this problem. And 12% have a sexual problem which is associated with a personal or interpersonal distress, which requires more evaluation, assessment, and a structured management, which unfortunately is not provided to these women. More often than not, when you look at any stages of sexual activity, be it the male or the female, we usually have three stages. The first one is the desire or the stimulus that induces a need or want to partake in a sexual activity. Then you have the arousal stage where your desire to participate in the sexual activity increases. And finally, this ends with orgasm, where people have a culmination of their sexual activity. And then there is a recovery stage, or what is generally called the latent period between which you cannot participate in another sexual activity. More often than not, for practical purposes, even though DSM-5 gives us 4 stages, desire, arousal, orgasm, and resolution. Classically, we describe it in 3 stages, which are the desire, arousal, and the orgasm stage. More often than not, when you actually look at these 3 points, directly, it gives you an understanding of the various stages which are involved in sexual activity. One, the psychological stage, which puts you in a point of mind where you start desiring sexual activity. Then arousal, which is again under the stimulation of the neurological system, under the stimulus of the endocrine system, and also requires proper functioning of your reproductive organs, which also involves the urology and the gynecology parts. And orgasm, which again is a function of hormonal activity, urological activity, as well as neurological activity. But since I'm an endocrinologist, and even though this is a huge field, I'm going to focus mainly upon the endocrine aspects of hyperactive sexual desire in women. This is often underrated in the genesis of HSD, and we have multiple hormones which play a key role in this aspect. Estrogens are known to play a major role in the evolution of sexual desire. Androgens also, we are increasingly recognizing that androgens are also essential in women. And androgens play a major role in female sexual activity. Thyroid hormones, which are often underrepresented, both hypothyroidism as well as hyperthyroidism, can have a major role in poor sexual activity and poor sexual desire. And we are increasingly recognizing that monoamines, especially the dopaminergic system, has a major role in desire, arousal, and satisfaction in a female sexual activity. Most important, and this is something with which I'm sure all of us are familiar, especially around the perimenopausal and the postmenopausal women. Post-menopause, the deficiency of estrogen plays a major role in decreased libido and the reluctance of women to initiate sexual activity. This is because estrogens have a major role in making the pelvic organs resilient enough for comfortable intercourse. If you have poor estrogen reserve, if you have poor estrogen activity, many a time women have a dry vagina, which leads to dyspareunia, and which later on translates into an absolute reluctance to participate in sexual activity. Sense organs are primed by estrogens, which are the key receptors for external sexual stimuli. These also affect the sense of touch perception, vibration sensation, and clitoral sensitivity. And estrogen activity is also vital to the adequate functioning of the monoamines, serotonin, noradrenaline, and dopamine in women, which have a major role in arousal, initiation of intercourse, and completion of intercourse. In all these aspects, estrogens have a major role, and this becomes obvious to us mainly around the perimenopausal and the postmenopausal stages in women, which is when they start becoming estrogen deficient. Our first understanding of the importance of androgens in intercourse and hyperactive sexual desire was first described in the late 70s and early 80s when a syndrome known as female androgen deficiency syndrome called FADS first was described and came into presentation. It was a symptom complex of loss of pubic hair, diminished muscle mass, and marked decrease in libido. This was commonly seen in women who had a breast cancer. Subsequently, they had an oophorectomy, and in those days, in the early 70s and 80s, to prevent the conversion, before we had major estrogen modulators or estrogen antagonists, because it was assumed that the adrenal gland also had a major role to play in the development of estrogens. Many of these women also had an adrenalectomy to prevent the secretion of and conversion of estrogens which had been produced from the androgens which had been produced in the adrenal gland. Subsequently, these women, because they did not have any androgens, be it produced either from the ovary or from the adrenal gland, developed this female androgen deficiency syndrome, which was marked by a significant decrease in the libido. And subsequently, once this was identified, supraphysiological doses of androgen therapy were found to increase the libido and sexual frequency. Later on, this practice of doing an adrenalectomy actually came down, but the identification of this condition persisted and the fat syndrome persisted. And subsequently, androgens have been recognized increasingly to have a major role in female sexual arousal and desire. Classically, the major androgens in female are DHEAs, dehydroepiandrosterone, androstenedione, testosterone, and dihydrotestosterone. Almost all of these in various forms have been used for the management of decreased sexual desire in women with variable caveats and variable success rates. But we still understand that our knowledge of androgens and its role in libido is still very limited. For instance, in PCOS, we have increased androgens, but these androgens have been reported not to have any major sexual effects, either an increase in libido or a decrease in libido. So whether these androgens play a significant role only in postmenopausal women or perimenopausal women, and the impact of androgens in the setting of estrogen deficiency as in perimenopausal women versus setting where there is no estrogen deficiency as in women with PCOS is still yet to be worked out. Androgens are still a very gray area as far as we are concerned, and they are now being prescribed for some women, but right now they do not have FDA approval as such, and use of this is still very much limited. Surprisingly, contrary to what we generally assume, the role of diabetes in female hyperactive sexual desire is extremely uncertain. Among all the studies which have been done with diabetes and female sexual desire, only one study has actually found reduced genital sensation in female with diabetes, in absolute contradistinction to what is seen in males, where diabetes plays a major role in decreased libido and decreased sexual desire. Most studies comparing sexual dysfunction in females with or without diabetes have actually yielded inconsistent results, and at this point of time, we cannot assume that diabetes is a major cause of hyperactive female dysfunction. Hyperprolactinemia is again very well known. Prolactin acts at the level of the pituitary, reduces your LH, reduces your FSH, reduces your estrogen. To some extent, because of its reduction of LH, it also decreases the production of androgens in the ovary. And it has been associated with lower scores for sexual desire, arousal, lubrication, orgasm, as well as satisfaction. Almost all the stages in the female intercourse. Hyperthyroidism, more important than hypothyroidism, is a known risk factor for increased sexual dysfunction. Very few studies have actually been done in hyperthyroidism women with regard to sexual desire, because more often than not, when somebody presents to the OP with hyperthyroidism, the concerns are something else. More often than not, we focus more on the thyroid-associated ophthalmopathy, the cardiac effects, and the skeletal effects. And sexual desire is often pretty low down on the totem pole as far as the evaluation is concerned. But there was one meta-analysis which actually included 3 case control studies. And in this, overt hyperthyroidism was associated with a 2-fold higher risk of sexual dysfunction when compared to the general population. The big Achilles heel of these studies was that nobody had actually compared the sexual dysfunction in subclinical hyperthyroidism with people who had a normal thyroid function. But as the current data stands, very small data, overt hyperthyroidism is associated majorly with sexual dysfunction, probably because it causes a decrease in the free testosterone because of a rise in sex hormone binding globule. More often than not, when patients present to us with a hypoactive sexual desire, drawing these women first into the conversation itself is an extremely difficult thing, be it a male endocrinologist or a female endocrinologist or a male doctor. Unless and until the patient directly approaches the doctor with this problem, it is very difficult for us to find out a solution. And many a time, we also have to involve a lot of other doctors in this, a gynecologist, if it's maybe a female urologist, because many women have a problem consulting a male urologist for these issues. We also might have need to involve a neurophysician and a psychiatrist. More often than not, the first major step in identifying a female hypoactive sexual desire is to elicit that history from the patient and indubitably identify that there is a problem, rather than this being a miscommunication between the partners. For this, we need to have some diagnostic criteria which have to be established through the medical and sexual history. Genital examination also needs to be done. This is not possible for a lot of us endocrinologists in the general OP, and this is for this reason that we refer them to the gynecologist. And it helps you in establishing this problem if you use some of these SET questionnaires. There are multiple screening questionnaires which are used in hyperactive female sexual desire topic, and I'll give you an example of one of these later on in the presentation. And subtly, especially in a conservative society like India, we need to probe for substance abuse, especially alcohol, drugs like marijuana, or even smoking, which can induce a sexual dysfunction, or also look for medication-induced sexual dysfunction, the commonest of which are antipsychotics. More often than not, this is how a typical evaluation proceeds. If we do have the time, in a majority of times in the routine endocrine OP, we don't have the time. We do have to set some time apart for this. Probably ask the patient to come to us on a day when there are lesser patients, or allot a different time to a patient, discrete from our regular OPs, where we can delve deeper into their history. Take a good gynec history, which includes symptoms and conditions that may affect the sexual activity, or need for further evaluation, including looking at the menopausal status, whether there was any surgical menopause, whether there was any salping oophorectomy, or the patient had chemotherapy. Especially alkylating agents are majorly responsible for these kind of problems because of hormonal issues. History of pregnancy, childbirth, especially history of trauma during childbirth, any vulvovaginal or pelvic injury, cancer or surgery, any dyspareunia during intercourse, symptoms of infection like pruritus, dryness or discharge, any abnormal genital tract bleeding, which can again indicate neoplasia, urinary or fecal incontinence or prolapse, history of fibroids, history of infertility. Where possible, within bounds of reason, you can take a sexual history or delegate it to somebody like a psychologist who's associated with your clinic, or the gynecologist, and go in for a pelvic examination, which again has to be done properly in a systematic manner, ideally by a gynecologist. And this is one of the screeners which I was telling you about, which gives you a brief assessment. This is basically how you approach them. You take, this is not a Likert scale, this is a simple yes or no scale. You take history of level of sexual desire. Was it better earlier, or has it worsened now? Is it really distressing to the patient? Does the patient actually desire an increase? If the patient does not desire an increase or does not want to go in for intercourse, then there's no point in going ahead with this assessment. If the patient is aware of this and the patient is coherent enough to give us answers to these questions, we take history of operation, depression, anything which could have contributed to this present condition, history of medications, recent pregnancy, classically rule out dyspareunia, which might have a very organic cause, and the minute it is resolved, this problem might remit. It's also very important to take note of the partner sexual problems, especially because when the male component is involved, and a lot of times the males might not be very forthcoming with their sexual problems because of risks of male image, dissatisfaction with the relationship or partner, and especially in this present era when many people work from home and they're already on the job 24/7, risks of stress or fatigue related conditions which can contribute to decreased sexual desire, which is an often understated causative factor in decreased female sexual desire and can lead to major problems, and which is almost always present in any person who even has an organic decreased sexual desire, because once these problems start, the psychogenic, the stress component always kicks in. Basic endocrine evaluation: do a thyroid profile or at least a TSH, iron stores for hemochromatosis. If somebody is premenopausal or they have history of amenorrhea, look for estradiol and FSH to rule out a premature ovarian failure. Always make sure that you check out the serum prolactin levels for reasons I've always told you. Androgens, again, it's a huge question. What androgens exactly are you going to evaluate? Because many a time androgens don't give us a good clue as to the hormonal reasons for sexual dysfunction. You can do a sex hormone binding globulin, especially in the setting of hyperthyroidism. Free testosterone by equilibrium dialysis, which is the gold standard, but often not done. Total testosterone, ideally by an HPLC, or a good method. Do the DHEAs, but this often doesn't contribute much to our understanding. And if you suspect adrenal insufficiency, do an early morning cortisol. Management again involves complete evaluation and diagnosis. Use the screener, go into the history of the patient. And once you confirm that the patient has a hyperactive sexual desire disorder, look for patient goals. What exactly does the patient want in this condition? What treatment does the patient want? Counsel the patient as to what they clearly want. Counsel them as to their fears, their expectations. Address partner issues which cannot be stressed enough. Treat the associated conditions, be they hormonal, be they urinary tract infections, be it a cause of dyspareunia. And most important, this is one thing which cannot be done by a single person. We neither have the time nor the resources to do it in a singleton manner. We have to use a multidisciplinary and a multimodal approach. It goes without saying that the minimum partners who need to be associated in this are a gynecologist, a psychiatrist, and if there are some issues, also involved a urogynecologist or a urologist, and neurophysician are the bare minimum doctors who need to be associated in this evaluation of female hyperactive sexual desire. Treatment proper, ideally, as long as, unless and until we find an organic cause, non-pharmacological options are ideal. Counseling is the single most important thing which enhances the need for participating in intercourse and sexual desire. Wherever possible, going for psychotherapy and psychopharmacology, keeping in mind that a lot of medicines which are used in psychopharmacology can by themselves cause decreased sexual desire. Only go for those agents which are not known to affect the sexual desire. Lifestyle changes, a major component of which is reduction of obesity. Because obesity has been known to suppress LH and FSH production at the hypothalamic and pituitary level. And a simple reduction in body weight can decrease these hormonal changes and also cause an improvement in the patient's body image. If you want to start people on androgens, make sure that none of the commonly used androgen therapies are approved by the FDA. We need to give the patient a full explanation of the potential benefits and risks. Testosterone therapy is the most commonly studied androgen treatment, can be given with or without estrogens. Ideally given in perimenopausal women, but make sure that you do not give them any supraphysiological dose. The most studied dose is a transdermal testosterone patch, which delivers 300 micrograms per day of testosterone with hyperactive sexual desire. This has been studied well for up to 6 months, but again, you always have this question which you get with any testosterone therapy, be it men or women. How long are you going to continue with this? As an initial test, you can continue it for up to 6 months in women, postmenopausal women who got a hyperactive sexual desire. If it yields benefit, you can perhaps stretch it slightly longer. If within 6 months you have not had any benefit with this therapy, it doesn't make sense to go forward with this therapy. DHEA has been ideally studied in a lot of settings, which is one of the most commonly used medications, which has been aggressively recommended by a lot of people who are involved in treatment of these disorders. In a few studies only, it has been shown to improve sexual interest and satisfaction, but it is ineffective in those who are perimenopausal or naturally postmenopausal. Ideally, it's given in people who have a premature ovarian insufficiency. The best method of administering this is a low-dose vaginal DHEA. Typical 75 mg DHEA tablets, which are used in fertility therapy, have no role in the management of female hyperactive sexual disorder, hyperactive sexual desire disorder. Estrogens, again, the reactions have been mixed. The Women's Health Initiative in 97 actually showed that systemic estrogen with or without progesterone did not improve sexual satisfaction. The only indications for use of estrogen are in those who have severe menopausal symptoms, which precludes participation in intercourse. And like I've already told you, in very dry vagina or where you have dyspareunia, which is because of decreased estrogen, postmenopausally, vaginal gels have a major role. Tibolone is another synthetic steroid whose metabolites have estrogenic, progesteronic, and androgenic properties, but it is not approved by FDA because of its perceived risks of breast cancer, endometrial cancer, and stroke. It is predominantly used in Europe, more effective than estrogen progestin therapy for treatment of sexual dysfunction in postmenopausal women. But again, this comes with a black box warning and it is not extensively used for the management of this disorder. Recently, we've had a couple of drugs which were approved by FDA for female sexual dysfunction in premenopausal women only. More often than not, This molecule is used at a daily dose of 100 mg at bedtime with severe cautionary notes in premenopausal women with low sexual desire. Major side effects of this molecule are hypertension and syncope. These are increased when combined with alcohol, and patient has to be told of the major side effects of the use of this molecule. Recently, in 2019, another molecule, a melanocortin receptor agonist, was approved by FDA for treatment of hyperactive sexual desire, again in premenopausal women. None of these women, treatments are for postmenopausal women. A subcutaneous injection of 1.75 mg at least 45 minutes before the anticipated sexual activity. But because this molecule is known to cause hypertension, should not be used in women with uncontrolled hypertension or known cardiovascular disorders. And since it is very well known that hypertension itself is a major cause of hyperactive sexual desire disorder in women, monitoring measurement of BP and monitoring of BP is mandatory before you start this molecule in any women. This is a brief algorithm for care and management of hypoactive sexual desire in women. First, establish that you have a decreased sexual desire disorder. Educate the women. Look for other organic causes. And once you have educated them, look at whether they are premenopausal or postmenopausal and go with therapy, hormonal therapy, as well as CNS agents, depending on whether they're premenopausal and postmenopausal. And most important, follow up these women and assess whether your treatment is working or not, whether you need to stop the treatment, escalate the treatment, or switch to an alternate treatment. There are multiple algorithms. This is one of the commonly used algorithms, which is recommended for this disorder. Coming to men, hyperactive sexual desire in men is very well known. A lot of focus has been given to this. The prevalence ranges from 14 to 17% in men between the ages of 6 to 59. Once older men become older, this actually increases because of risk of andropause. The major problem with this disorder is because of perception of male superiority. Many of the population ever deny actually having this problem. Eliciting this history becomes a major problem in men with hyperactive sexual desire. Unlike women who are usually indifferent to this, men tend to actively conceal their problems of hyperactive sexual desire. As people age, the sexual desire capacity and frequency of sexual behavior declines. The sexual interest seems quite stable from teens up to the age of 60 years. Once people cross the age of 60, as testosterone levels come down, this problem increases, and many a time depression or erectile dysfunction frequently coexist. Hormones, as always, have a major role in the genesis and the maintenance of this disorder. Serotonin is thought to be the principal neuromodulator mediating sexual arousal and desire. Testosterone can modulate this system. Mind you, testosterone is not necessary for the initiation of sexual intercourse, but libido has a very strong link to testosterone, and decreased testosterone can cause a decreased libido. Testosterone has a major role in initiation of testosterone therapy has a major impact in increasing libido and increasing the sexual desire in men, especially hypogonadal men. Dihydrotestosterone does not have such a major role. Prolactin has a major role in decreased sexual desire, again for decrease in LH, FSH, and testosterone. And in severe hyperprolactinemia, this can be manifest majorly. Estrogens are again equivocal. Cortisol again does not have a major role because unlike in women, the bulk of the androgens in men are produced from the testis and not the adrenal. Psychiatric disease, especially depression, can have a major role in not only sexual desire, but also in libido and erectile dysfunction. Endocrine disorders, hypothyroidism, hyperthyroidism, hypogonadism, hyperprolactinemia have a major role. Systemic diseases in men, especially chronic renal disease, hepatic disease, HIV, hematological disease, mainly because of their vascular changes and also because of their effects on the hormonal system, can have a major role in desire. Use of antipsychotics, both men and women, can have antidepressants, can have a major effect on sexual desire. And drugs which interfere with androgen production, like anti-androgens, use of anabolic steroids, mainly common in bodybuilders, 5-alpha reductase inhibitors, epileptics, and lithium. And substance abuse, especially alcohol, can have a major role in sexual dysfunction. Like Shakespeare put it in Macbeth, alcohol provokes the desire and takes away the performance. And it is very well known that alcohol is a major cause of erectile dysfunction in men and decreased sexual desire in men. Whenever we come to the assessment of men, we have a lot of tools. It is fairly straightforward. First, make sure that people can have a lifelong decreased sexual desire and erectile dysfunction. It can be a congenital problem also. Take a history whether it is lifelong or acquired. Look for predisposing and precipitating factors and factor which maintain it. Anxiety and depression are more often than not a maintaining factor even when the organic factors have come down. Look whether it is only situational because of problems with the partner, whether there has been any past trauma, and also look for the medical and iatrogenic factors which have already been elucidated above. Look for physical signs of endocrinopathy, true for both sexes or also for chronic illnesses. Evaluation is again pretty similar. Testosterone levels, LH, FSH, look for the prolactin, look for the thyroid hormones. And you summarize your evaluation, whether it is lifelong or an acquired cause of hyperactive sexual desire. Is it generalized or situational? Or is it a primary problem, or is it secondary to another medical problem or a hormonal issue? As far as we do a general examination, and then first line lab investigations are always the testosterone levels, thyroid profile, hormonal levels, especially prolactin, LH, FSH. If any problem is confirmed, is not confirmed, we look for investigate associated sexual dysfunction. Look at the partner also. Take a more detailed psychological interview. Involve a neurophysician or urologist at this point of time. But if we have a confirmed organic cause, again, investigate the associated factors. Look at if it is established that the patient has a hyperactive sexual desire disorder. Consider psychological as well as pharmacological support. Look for drugs which affect the libido. Look for hypogonadism. If possible, try to start them on hormonal therapy. Try to involve these people in couple therapy, which again involves use of a sex therapist or a psychiatrist or a psychological person, psychological specialist. Look for substance abuse, lifestyle changes. Obesity is a much more common cause of hyperactive sexual desire in men as opposed to women, because obesity causes what is known as male obesity associated secondary hypogonadism, which can cause severe erectile problems as well as hyperactive sexual desire. Give them a lot of psychological support, especially males need it a lot because erectile dysfunction always has a component of psychological activity. And if you do not address it, even if the organic cause is treated, this problem is not going to change. If it is situational, again, take them into couple therapy, take them into counseling and give them reassurance. Like I've already reiterated, this involves what is known as a biopsychosocial model, where you address the biological factors, psychological factors, as well as the social milieu of the patient, and looking at a couples approach. And like you have said with the female, you also have to have a prior agreement on the treatment goals, how much you can achieve with a male depending on the age and the pre-existing condition. Psychotherapy is appropriate in all situations, and prescribing or changing medications alone is not satisfactory. This is something which cannot be done by the endocrinologist alone. You again need a multidisciplinary approach. To conclude, this condition is very common in men and women, but it is often not discussed either because we do not elicit history or there is a lot of social stigmata associated with this condition. Multiple factors, including organic, psychogenic, social, and partner factors, are involved in the genesis of this condition. This requires a detailed assessment, ideally not as a part of your regular OP. You need to employ some of the commonly used questionnaires, evaluate their patient both physically, psychologically, and most important, hormonally also, and involve other specialties in the management of this condition. And you always have to ensure that whoever the patient who's treating somebody with hyperactive sexual desire is, it is mandatory that the hormonal component has to be addressed before you go ahead with other partner therapy, as well as looking at drug therapy or social therapy. Because if you do not treat the hormonal condition, especially in the setting of hypogonadism, or hyperthyroidism or hypothyroidism, we are not going to get the ideal outcomes for the patient. So always make sure that an endocrinologist is also a part and parcel of this assessment of hyperactive sexual desire in women. And we need further studies and further data also from the Indian subset before we can actually start developing our own questionnaires. And in this regard, I'm happy that this topic is being included in this meeting, because as the further talks which are going to go on for the rest of the day will help us shed some more light on this very often neglected part of your endocrine workup. Thanks a lot. And if there are any questions, I'd like to take them.
Thank you, Srinagesh sir. We don't have any questions. That was a very good talk. And despite of being a difficult topic, you made it look very simple with a very lucid presentation. And thank you once again, despite of not being well, taking pain and presenting. Thank you.
Thanks a lot. Right. Thank you.
Thank you, sir.
Thank you.
Next, we have Dr. Pramila Kalra ma'am, who will be talking about gender incongruence.
Yeah, so I'll just share my slides.
Can we have the CV, please?
Okay.
Yeah. Currently, Madam is Professor and Head of Endocrinology at Ramaya Medical College, and she has won multiple prizes for her paper and poster presentations, and has also won ICMR Scholarship Award for 2006, and she has also won the AR Seth Award for Best Presentation at ESICON 2006, and she has also won the A.V. Gandhi Award, which is a prestigious award for the excellence of endocrinology in 2008. And she is a member of many reputed institutions, and she has many publications on her name. Over to you, ma'am.
Thank you. Thanks for the kind introduction. I'll just be sharing my slides. One second, just sharing. I think my slides are there. Yeah. So at the outset, I thank the team of Hormone India to invite me for this meeting. And actually, topic is a little bit broad. So because my topic was gender incongruence, but I know that in the next session, Dr. Deba Malia is going to talk about the gender affirming hormone therapy. So I won't be going into much of details of that. I'll be going into the initial details of how to diagnose and when do we suspect gender incongruence, and how do we go about treating it, and then little bit about the therapy, because I'll just go little bit into the therapy and I'll not discuss the details about it. And then I'll also talk about some of our data which we have done for our patients with gender incongruence. So whenever we talk about gender incongruence, we know that we have different terms which come to our mind. So we know that there is a terminology called as a gender identity, when the person they identify themselves as female or a woman or a girl or a male or a man or a boy or the other gender. And then there's a gender expression where the patient, though maybe a female, but the expression may not necessarily be feminine, or it may be a man, but the expression may not necessarily be masculine. And then we have a terminology of definitely a sex assigned at birth, whether the child is assigned as female or male or as a intersex. And then what they are physically attracted to, whether they are attracted to a woman or a man or to other gender or to both. So all these things are there. And then there is also an emotional attraction. So just to understand this gender incongruence term, basically this is an umbrella term where we say that the gender identity or the gender expression differs from what is typically associated with the designed gender. So patient may, with the assigned gender, so patient with a designated gender. So patient may actually be born as a male, as a biological male, but may not identify himself as a male and may identify herself as a female. So that is what we say as gender incongruence, because the patient actually is a male, born biological male with the XY karyotype, is a phenotypic male, is a normal male, but does not have the identity of a male, but has the identity of a female. Similarly, a woman may be born as a female and she may be assigned a female gender at birth, but her identity may be a male and she may be called as a trans male. So this is how the gender incongruence is. And we know that it's not necessary that if somebody has incongruence, they're going to have dysphoria. They may have dysphoria, they may seek treatment, they may not. We have many patients who come to us very late, like around now they have come to us at the age of 60 or even at 55, and now they are seeking treatment because they never thought that they need to, or they were not interested and now they think they want to, or some of them are staying as the same gender which they were assigned to at birth, but they don't want to come out as the opposite gender, but they they think like the opposite gender, they want to behave like the opposite gender, but they don't have so much of dysphoria. So we may have patients who may want to, we may have patients who may not want to. When we say gender reassignment, we know that this comes under the terminology when we are doing some procedure for those who want to adapt their bodies to the opposite gender which they want to. And whether they will go for just the cross-dressing, whether they'll just go for hormone therapy, or they may go for reassignment surgery as well, which we call as a gender-affirming surgery or the gender-confirming surgery. And gender role, I already discussed, like the behaviors, the attitude and the personality traits that a society in a given culture or in a particular historic period, it designates as masculine or feminine. Now, when we talk about the terminology and when we have to approach these patients and how to approach exactly. So first thing is we have to have a criteria. So we know, as we told, that a patient should have a marked incongruence between the one's experienced or the expressed gender and the natal gender for at least 6 months in duration. And actually the patients who come to us have this for many years. Like most of the times, it's not just a matter of 6 months. They may be living like that for 4, 5 years, 6 years. As I told you, some clients are coming to us at the age of 55, 60, and they have been living like that for 30, 40 years. And they should have a strong desire to be rid of the one's primary, secondary characters, secondary sexual characteristics, or because they have marked incongruence with one's experienced gender or the expressed gender, a strong desire for the primary or the secondary sex characters of the other gender to be done, and they should have a desire to be of the other gender and to be treated as the other gender, and a strong conviction that one has the typical feelings and reactions of the other gender. So they should have at least 2 of the following. And when it is associated with distress, then we label it as gender dysphoria exactly, but now we use more of the term as gender incongruence. So when we say transsexualism, ICD-10 was there. Now we know we have ICD-11. I'm going to discuss that as well. So transsexualism has 3 criteria, like desire to live and to be accepted as a member of the opposite gender. And the transsexual identity has been persistent for at least 2 years. And this is not a symptom of any other mental disorder. So that is also important. Now, the new thing which has come up in this is that trans-related categories have been removed from the chapter on mental and behavioral disorders. So these trans identities are primarily, we are not trying to say that they are pathological, and we are saying de-psychopathologized in the ICD-11. So we don't call them as pathology. We say that they are normal. And because there was too much of stigma associated with the ICD-10 and they were labeled as abnormal, they were labeled as having some psychiatric disorder. So now we say that this ICD-11 says it is basically we have a transitional version, and it is step towards depathologization, and we are saying that they are not pathological and it is normal. It is not something a psychological disorder. It is a normal way of life, and this is how it is. And when we talk about children, we know that for children, we need to be very, very careful, because a lot of kids also are brought to us and they also have the similar type that they want to be of the opposite gender. They want to wear the clothes of the opposite gender. They have a strong preference for the cross-gender roles. They want to play with the gender of their choice. Like if it's a girl, the trans male, they want to play with a boy. The trans female may want to play with female. So this all happens, but it is very, very difficult, because we know that this may persist, this may not persist. There may be children who may persist to have gender incongruence when they grow up. There may be children who may not persist. There may be desisters as well. So we also have to be very, very careful, and it has to be done strictly in consultation with the child psychiatrist. Now we know that we have our IDEA group consensus guidelines, which have been given for both gender reaffirmation as female as well as for gender reaffirmation as male. And these guidelines are available on the website, so anybody can go and read that, but I'll be discussing a little bit about it. So when we talk about an eligibility, when do we say that patient is eligible? Now we say that this is not a psychiatric disorder. So should we not take a psychiatric consult? No, we do take, not for the reason that we want a psychiatric consult to label them as gender incongruence, but for the reason to see that they don't have any other psychiatric disorder. because many a times there may be some personality disorders, there may be some other disorders which may be mimicking gender incongruence, and we may label a patient as gender incongruence. Like I had few patients who came to us directly and they were wanting to be of the opposite gender, but when we took the history in detail, they were actually not gender incongruence. They wanted it for some or the other reason, but they were actually not fitting into the criteria of gender incongruence. And many of them have actually not been put on therapy, and they actually did not need therapy. And when we worked with our psychiatry team and the psychologist team, we came to know that they had many other personality disorders which were mimicking gender incongruence. So the reason for taking a psychiatry consult is to rule out any other disorder which can mimic a gender incongruence patient, and to be very sure that there is no other mental health disorder which can be exacerbated by the use of the hormone therapy. Because many a times when we start them on hormone therapy, especially estrogens, they may have a lot of mood swings. They may even develop sometimes suicidal tendencies as well. So all these things have to be taken into consideration. So patient has to have a well-documented gender incongruence and the dysphoria associated with it when we start the hormones, and they have to have the capacity to take this decision. Normally, we take an official consent with them in our OPD before we start the hormones, because most of the patients who are coming to us are of the age of 25 to 28 years, not below that. But the age of majority in our country is 18 years. Only above that we start. Before the age of 18, we don't start gender affirming hormone therapy. We can start puberty blockers once the child has reached the Tanner stage 2 and once we are sure of the diagnosis, but we never give them gender affirming hormone therapy before the age of 18. We give them puberty blockers in case they come to us before and the parents are ready. And only once they cross the age of 18, we start gender affirming hormone therapy. So what are the goals? Like we also have to see, like if we are starting in children, as I said, it is only the puberty blockers. There's no hormone therapy for the cross-sex hormone therapy given. Only when they are above the age of 18, we are starting. They should have the capacity to consent. So meaning to say is they should be in the proper mental health. They should be screened for any pre-existing health conditions which may cause problems with the hormones. And patients' expectations, it has to be realistic. Many a times the patients think, and they come with very unrealistic expectations. They think that after we start hormone therapy, they'll be exactly looking like a female. And many of them actually think that they can be implanted with a uterus, they will be able to bear a child. All these misconceptions are also there in many patients. So we have to first clearly tell that what we are doing, it will be more of a phenotypic conversion only, external conversion. It will not be an internal conversion. And the parents for trans males are very happy because they think they'll get a boy. But we have to tell them that this is only going to be a phenotypic change. So that is why this has to be very, very clearly told. So this is our center data where this was our initial data when we was like starting the gender affirming hormone therapy clinic. And that time when we did this study, we found that most of the patients who were coming to us were graduates. They did have some employment because in a city like Bangalore, now people are very much aware and they are getting good jobs and they are engineers. Many of them are doctors as well, and they are all working. So they have information, they have the means to do it, and they know what they're doing. And we had all religion patients coming to us, and there were rural patients as well, and there were urban patients as well. But one thing which we saw characteristically initially was that they present at a later age to us. So this is very important because normally they are never brought when they are children. We get lots of kids with a diagnosis of gender incongruence, but the parents don't want us to start any puberty blockers. They just want us to give them hormones so that they don't go for gender incongruence or their mindset is changed. The lack of information is too much. The follow-up is very intermittent. That's what we still see in our practice. Many are not educated as well, and the family support is very less. But over a period of last 15 years, I have seen that the family support is increasing. And now more and more of my clients are coming with parents actually. So that's a good thing because knowledge level and the information is increasing. So when to start, we should have an assessment of the individual's expectations. We have to tell them the realistic goals, what is going to happen, and we have to take a thorough medical history. Many of them are retro positive, and we have to tell them that if they have to tell us the whole history. Sorry, there is some disturbance. Can we please mute? So yeah, thank you. So we have to take the whole medical history, and we also have to see that initial evaluation with the full personal and medical history is done. I always inquire about their family, their psychiatric illness. Substance abuse is very important. I have lots and lots of clients who are doing substance abuse, and we need to know any previous history of cardiovascular disease, and the most important, obviously, metabolic history of diabetes and other things, but not to forget about their fertility desire history. Because many a times they don't know, and many of them have undergone orchidectomy from different places, and they don't even know that there is an option of sperm banking. They have undergone hysterectomy, they have removed their ovaries, they have undergone oophorectomy, and they had no idea about ovum banking. So that all has to be told to the patient. So anticipatory communication is very important. Open discussion, language which the patient is comfortable. Perform the examinations when necessary in front or with your nurse, and ask the patient they want a male or a female, because many times they are not comfortable with a particular gender. So you have to do, if you have to do the breast, genital, and the rectal examinations whenever necessary. Not necessary for everybody, but if you want to do, please do it with people standing with their choice, like they want a male nurse or a female nurse. According to that, you have to be there, but the nurse or the person they want should be there along with you, because that's very, very important. Informed consent we always take in our OPD, so that patient understands the risk and the benefits of the hormone therapy, and we tell them about the adverse effects and what's the future and what all problems can happen. We also tell them. Now, treatment plan, basically, I know the next speaker will be discussing in detail about the hormone therapy. So I'll just go into a little bit of it and not much of it. So basically, we are trying to suppress the natal gender characteristics, and we are giving treatment to give the desired gender to the patient, phenotypic gender. It is not going to change the internal things. So the goal is to reduce the endogenous sex hormone levels, reduce the secondary sex characters of the individual's designated gender, replace the sex hormones consistent with the individual's preferred gender identity, that is the cross-sex hormones we call it, and using the principles of hormone replacement for the hypogonadal patients. That's the principle we use. So when we are doing male to female, we do these baseline tests. We do check their metabolic profile. Prolactin is important. We check their hormonal levels. Karyotype is also important, and we always do it. In case they are not affordable, we don't do it if we are very sure. But we have caught many patients who are DSDs who were not actually gender incongruents, and they were labeled as gender incongruents by the psychiatrist. So that's very important, that if you have a doubt, please go into the detailed evaluation. We even had to do FISH and other tests for some patients, because they were not actually gender incongruents. They were actually 1 of 2, 3 were Klinefelter syndrome, and there were patients with CAH also who came to us. Cardiovascular risk assessment is important. BMD is preferable. We normally do it at our center. So transfeminine, we have to give estrogens. We can use oral tablets. We normally go up to 6 mg, but very few may need 8. Estradiol patches we are also using for our patients, and injectable we are not getting at the moment. Anti-androgens, we mostly use spironolactone if they don't afford the leuprolide. Otherwise, we go with the leuprolide with the GnRH agonist. Cyproterone also is used for few patients, but a higher dose is not available in our country. Now, if we talk about the time frame, we have to tell them that how the things will happen. We have to tell that first 3 months, they'll have a lowering of the libido. First 6 months, they may see some breast growth. Over a period of time only, they will see over 1 to 2 years, the things will start changing, and maximum body fat redistribution, they will see over a period of 2 to 3 years. We also should remember that we have to have other procedures like dermatological procedures, voice training, cosmetic, breast augmentation. All these have to be discussed when we are doing the trans female, that is male to female. And orchidectomy and vaginoplasty is patient's decision. They have to decide about these therapies if they want to go ahead or not. Our job is to tell them all the options. So I'll also go to a little bit of this, that we know that the estradiol and the testosterone levels should be kept in the range for a female in a trans female, that is the 100 to 200 picograms per mil, and testo concentration has to be kept lower in the normal female range. If the patient is not having the requisite benefit and the levels are not okay, we have to increase the estrogen dose. Transdermal preparations can be an option because the side effect profile is a little bit less and better with transdermal. Spironolactone, if the patient is taking, we can increase the dose if the testo levels, if you want the testosterone effect to come down, it won't reduce the level so much, but leuprolide can be used to reduce the levels as well. And we also need to tell them about thromboembolism, because this can be a rare side effect in very few patients. Follow up with their lipids and their metabolic functions, the glucose levels, liver functions may be needed in over a period of time as we follow them up. And we also sometimes need to follow up the cardiac part, because these things are very important, because many times we do get patients at older age. I have patients around 45, 48 who have started first time the hormones. So we had consultations with our cardiologist, and we decided that we'll not give beyond the age of 50, because that's the normal age of menopause what we take. So that's the time what we maximally give. Beyond that, we mostly don't give. Now, one thing which is always forgotten is prostate cancer, because they undergo orchidectomy, they dress up like a female, and nobody examines them and evaluates and will do a PSA for them. So prostate cancer screening is very, very important. That has to be done. And also, as I told you, metabolic health is very important. We need to follow them up for their diabetes, for their liver dysfunction, for the cholesterol, for the high triglycerides. All these things have to be seen. So overall, we know that there's not much data for long years, but we have data for 10 to 15 years now. And we know that vascular disease, thrombosis, oxidative stress, all these are interconnected. So we need to follow these patients for the cardiovascular health as well. This is one of our centers data where we tried to see the fasting insulin and the insulin resistance in these patients. And we did find that over a period of 6 months to 1 year, there was not much significant change in the body composition, but we saw that there was a little bit increase in the insulin resistance and the fasting insulin levels in these patients over a period of time, over a period of 6 months to 1 year. So bone health, we know that these patients should be screened. Calcium and vitamin D supplementation is very important. And we also did some data on the bone health, and we did find that there is a deterioration of the bone health in trans females, and there is a betterment of the bone health in trans males. So what we saw, that if the patient is put on female hormone therapy, and if they undergo orchidectomy also, their bone deterioration can be even faster. And that's why they need to be followed up for the bone health. So the transgender females who underwent orchidectomy actually had more bone deterioration at the hip and spine compared to the individuals who did not undergo the orchidectomy. And also, we know that this hormonal therapy can have effect on the muscle strength and body composition, because we know that the patients who are trans males may be better than the females in the sports, and the patients who are trans females will be poorer than the males in the sports. So that also has been studied in many studies, and we also tried to see that whether there is any change, and we did find the similar thing, that the trans males had a better body strength and the trans females had a deterioration of the body strength and the muscle mass as compared to the normal cis males. So mental health is something which is always forgotten. I always make it a point that they go and meet the psychiatrist in between and the psychologist as well, so that their mental health is also taken care of. Cancer screening is, as I told you, is very important. We know that breast cancer screening has to be done as per the cis female guidelines for the trans females. And prostate cancer screening is also very important. And also they in the neovagina, these patients can develop carcinoma. So they have to be screened for that as well, because this is also something which is forgotten and not done. And patients who have multiple sexual partners, they also need to undergo the anal pap smear as well. So when we talk about little bit about the female to male, we know that when we talk about female to male, we start with testosterone therapy, and it is mostly given in an injectable form. We also have gels. We also have used gels in few of our patients who had hepatic side effects with injectable testosterone. And we give a 4-weekly to 3-weekly to 2-weekly dose. And again, we want to keep the testosterone levels in the cisgender range, and want to keep so that it induces the secondary sexual characters. And most of the times, once we reach a dose of 250 mg once in 3 to 4 weeks, the menstruation mostly stops, and they don't need any other further hormonal therapy like the depo-progesterone or the leuprolide to stop the menses. But we also have to monitor these patients for the side effects as well as the effects. The skin oiliness and the acne is the first thing to come. So whenever I start hormones with testosterone, I always write treatment for acne as well, because by the time you do the next consultation, they already come to you with severe acne. Fat redistribution and the clitoral enlargement, the vaginal atrophy starts happening over a period of 1 to 6 months. Maximum is achieved by 1 to 2 years. So we have to monitor the testosterone levels and keep it in the physiological male range. Most important is to monitor the hematocrit or hemoglobin. So we have to follow them up with the hematocrit and hemoglobin. And if it goes higher, then we have to do the bloodletting, withhold the therapy for some time, and again restart. So in our center also, we have tried to again see the female to male, the insulin resistance, and we did not find much difference in these patients, except in the LDL and the VLDL levels, where we did find that there was some increase. And also the body fat analysis, which we did, we found that the patients had more redistribution of fat in those patients. The whole body fat also redistribution happens in the patients who were put on testosterone therapy earlier. So monitor for other things also, like hemoglobin, PCV, the liver functions, the thyroid. We also have seen in our setup, we are actually doing a study at the moment. We have seen that trans males do develop thyroid dysfunction over a period of time. So that also we are following at least once in a year if they are baseline normal with the TSH levels. And first 3 tests are to be done every 3 months. So my take-home message is diagnosis is the most important. I have patients with Klinefelters who were diagnosed as gender incongruence. I have patients with CAH who were diagnosed as gender incongruence, and they came to me for hormone therapy because the psychiatrist will only see their mental health. We have to see that they are actually gender incongruent. They are normal males or females, and then they have the identity of the other gender. Then we call them as incongruence. But if they have already some of the disorders, we have to correct that. Understanding the issues is very important. Social family support is very important. It is increasing, and we are seeing that more and more people are becoming aware. Regular follow-up is important. We have to stress the importance of follow-up at the first visit itself, because otherwise what happens, they take the prescription and they don't come back to you for 1 year. So that should not happen. If the side effects happen, don't bother to don't think about stop de-escalation. Do it as much as you want. Stop the therapy temporarily, no problem. I had patients who developed liver dysfunction, patients who had some severe problems with like they developed GI problems with estrogen. So all these patients, you might have to stop, shift to an alternative method if possible. If everything else is fine, like if the patient is not tolerating oral, you can think about patches. Similarly, if the patient is getting side effects with the injectable testosterone, liver dysfunction, you can try the gels. So all these things we can do, but de-escalate if you think it is needed for the patients and the side effect is happening. Fertility preservation should be discussed at each visit. Even if you have discussed it at the first visit, don't forget to discuss it at each visit, because patient might not have understood it at the first visit. At later visits, they are in a better position to understand. So please discuss. And these are few of our patients. This is Akai. Akai is the first transgender in Karnataka to get a transgender driving license. And Akai runs a big NGO here. She's a trans female. She's my follow-up, and she's doing very well. And she is helping many of the transgenders. And she is a MLA in Bangalore. She is also my patient. She's a trans female. So we have to understand that they can be normal. They'll work normally in the society, and we should accept them as they are. Thank you.
Thank you, ma'am. That was a wonderful presentation. Right. Currently, we don't have any questions. Just one thing I want to ask you is, how do you manage all these cases in your OPD? Do you have a counselor around with you? Separate counselor?
See, our counselors are our residents, and they are the best counselors, because we have a full team, and our nurse or the educator who is working with us, she has been there for a few years now. And she also knows, and she deals with all these transgender, and even our receptionist is there actually for quite some time. So they are all now used to talking to transgender, and when they come to our OPD, actually it happens like that they come for cold cough also, they are referred to endocrinology. They tell, okay, go to Dr. Pramila, she'll see you. And many times they keep on sitting, and we ask, why have you come? I have cold. Why didn't you go to medicine? Because they told go to endocrinology OPD. So we have made a system like that. So they are very much aware, and our hospital is very trans friendly. We also have a transgender ward. So our people are all aware of how to speak to them, and they treat them as normal patients. We don't call them on one separate day. They come in our regular OPD. We have a separate transgender clinic, but they come on regular OPDs also, and they are treated as normal patients, and everybody talks to them like they are as normal patients. We don't do that they are some separate group or something else. It's not like that, and they also understand that. So they feel very comfortable. So that's how we actually deal with them.
Thank you, ma'am.
Yeah, one more question from my side. For all those who are running a single OPD, not working in center, what are the legal aspect we should be looking at while dealing these patients? Because that's an important aspect, especially when you are alone.
Absolutely. Not even alone. Even if you are with a group, the legal aspects have to be taken into consideration. I had many instances where parents have come later and asked me that, why did you start the hormone therapy? You should have called us. So it is a usual problem. But the thing is, first thing we have to understand, that's why we always take a consent. That's the first thing I do. Previously, I used to actually make them get one affidavit also. But I don't know if Dr. Deba Malia is also doing that. But nowadays, they don't accept that getting an affidavit, because the problem is they say this is not required. So we can't force them. So what we do is we have a consent form. We take a consent from them, that because they are over the age of 18, we check their Aadhaar card. We have to be very sure. And then we take a consent, and then only we start hormones. So even if the parent comes to you, then you are not legally bound to answer them. But yes, we entertain them because we understand the problem. So we talk to them, we entertain them. But many of them are upset that you didn't call us. So that is not needed, mandatory. But as I told you, don't always go with the psychiatrist letter, because the problem is, as I told you, we have diagnosed so many intersex, we have diagnosed so many DSDs now. Actually, one DSD patient came and she was diagnosed as gender incongruence. When we diagnosed her as like she was a PAIS actually. So after that, she brought 5 more patients from her village, and she said they were all labeled as gender incongruence and they wanted to come to you for hormones. Out of that, 3 turned out to be DSD and 2 were only gender incongruence. So what I'm trying to say is they may not be gender incongruence. So our problem will only come if we make the wrong diagnosis. So always examine the patient if you have a doubt, because many times you will have a doubt. Examine, do all the investigations which you want. Don't worry about investigations, do it. Because if you don't do and start and later on we find out something, it is going to be a disaster. So do the investigations, take your time, no hurry. Let your psychiatrist be convinced, let you be convinced as an endocrinologist that the diagnosis is right. Take a consent and then start the hormones. And every visit, make documentation. Documentation is again important, especially about fertility prospects also, side effect profile also, because many times I have patients after 3 years, one patient got a stroke and the patient was taking testosterone 250 mg every 1 weekly. I didn't advise the patient was doing on her own. So on his own. So this is why we have to be very careful. So document that you have written. I have patients who were taking overdose of estrogens also, but we never wrote that. So we have to document, we have to tell that fertility options, cancer, side effects, everything have been explained. Every visit, write that. And in between, take a psychologist consultation always, because many of them have suicidal tendencies. They have a lot of mental health issues. So I always make it a point that 6 months to 1 year, once they visit our psychologist, so that they catch many times. They'll say, oh, your patient is having suicidal tendencies, and we didn't even know. Because sometimes they don't come out with those things to us. So those things are also important. So work as a team. If you are alone as an endocrinologist, no problem. But keep one psychologist with you who can be of help to see their mental health and all those things. Above the age of 18 years, they are legally okay to start, but please check the Aadhaar card. I always do that. Myself, I check. I always check original. I never take the copy.
Dr. Pramila, many patients, when we start hormone therapy, they want surgery immediately. For example, I had a patient of female, because we are starting male hormone treatment, and they want that I want top surgery right now, because it will be not you are getting beards and other things. So how to deal with that? Because
never ever give up to their demands. That's the answer. You always have to tell, this is how we go. This is the protocol. I always tell, the government of India has made these guidelines. I always use this word. It is made by government of India and our NMC, and we cannot change the guidelines, and our hospital does not allow us to do this. These 3 things I always tell, then they don't pester me. Never ever go against the guidelines. Follow the guidelines. If they want urgent surgery, you tell. I always try to delay. So I tell them, okay, I will see 2 months how you are doing, and then we will decide. Next time when they come, I tell them, okay, I think you should wait for 2 more months. Let me see your effects are coming very nicely. I mean, don't jump on for things. Then I might have to stop the hormone therapy for some time. Wait for some more time. Like that, I buy time. So I have many clients who want urgent surgeries, but I never let them do it. I somehow try to delay on an individual basis like that.
To match those expectations, especially related to voice and exact facial appearance of male or female.
Yes. So voice for trans males, no problem. They are very happy because the voice change happens. Problem happens in trans females because the problem is they are not satisfied with their voice change, and because they look like a female, but their voice won't change. So there are only few ENT surgeons who are doing surgeries for trans females also. Most of the time, the voice modulation actually works in many of them actually. go and get the voice surgery done. And he does a fantastic job actually. So you will find few people in your vicinity who are doing. We have one ENT surgeon in Bangalore who is doing, but I don't recommend voice change surgery immediately. I tell them you do voice modulation and try. And for the dermatological procedure, our dermatologist is doing few procedures where plastic surgeons are doing few procedures that is optional. So if they want to go, they can go for those rhinoplasty and other procedures, which some of the trans do go. Some of them don't want to, so they don't go. Most of the time, the trans males are more happy. The trans females are less happy.
When we start testosterone, many times they get acne and mood swings and all those.
Yes.
And then there's like you are in dilemma whether to go with the dose or decrease the dose. So how to deal with that?
So if that's what I told. When I write a testosterone prescription, first time I write the treatment for acne immediately. I give them face wash. I have a protocol. I write that. I write everything on the day one, because the moment, as I told you, when I do the second visit, the first thing they will say is not anything else. They'll say, my face is full of acne. Or if it is not the 3rd month visit, at least at the 6th month visit, their face will be full of acne. So we give them the therapy from the beginning. If you are unable to manage it, then take a dermatologist opinion. That's what I always do. But initially, I write a treatment so that the acne does not become severe. This is a usual problem. Tell them to take care of the skin hygiene and all those things. I always tell them. And then if it happens, then we have to give topical therapy. And along with that, take a dermatologist opinion if you are unable to manage.
Thank you, ma'am, for wonderful talk and detailed talk. It's very nice experience every time we discuss with you. So I think last year also you spoke on the same subject.
Yes. Thank you.
Okay, thank you. So with this, I think we are going ahead with the next session. Can we have slide of Dr. Dev Malya Sanyal? So I welcome Dr. Dev Malya Sanyal, sir. He's MBBS, MD, DMN Oncology, and he's international scholar Donald D. Esler and professor in oncology in KPC Middle College and Editor's Choice Publication in Diabetes India 2021. And he received international travel grant for paper presentation in AAC and various awards under his belt. And with that, I welcome Dr. Dev Malya, sir, to take talk on gender affirmative hormone therapy in transit.
Thank you. I would like to thank the organizers and especially Mayur as well for the kind invitation. And the last year I was talking about endocrine hypertension. This year I would be talking about the gender affirmative hormone therapy. Be just sharing the slides. Hope they are visible.
Yes, sir.
Okay. So gender affirmative hormone therapy is something we have just heard a lot. We have had a discussion with regards to the presentation by Dr. Pramila Kalra. So there are several guidelines, as we know, the most prominent being the WPATH guidelines as well as the Endocrine Society guidelines. We were also involved with the IDEA guidelines, the first guidelines from our part of the country, that is SAFO guidelines as well. So whom do we need to treat? So if we look at it, we need to have, as we were discussing, we need to exclude the other causes, but we need to have also a formal referral from the mental health professional. The diagnosis is very important, has to be confirmed. One, we have to confirm it is gender identity disorder or what is known as gender incongruence nowadays. And also we need to rule out other causes as well, whether it is hormonal cause, the other DSD also, we need to be very careful about that. But again, we need to also look at it whether it is persistent and well documented as well. So that is very important because, you know, there is now a lot of people, we have had at least 2 or 3 cases where people have wanted, do not want to go ahead after 3 to 6 months, after just initial evaluation, they say.
You're mute, sir.
We have learned about the informed consent as well as the age of maturity for our country is 18 years. And most important reason, for the mental health professional is that if a lot of these patients have some amount of mental health concerns, at least those should be well controlled as well. So there is depression, anxiety, suicidal ideation. We have already reported that as well, published that. There is a lot of substance abuse. That's again something, a big concern as well. Smoking is very much prevalent, and which may actually interfere with therapy. Alcohol abuse and others are very common. HIV is again something which is not uncommon in this population as well. So we have published, sometime back in IGM that, the average age of onset is about 9 years, but their presentation occurs quite late, especially to us, it's about 25 years, though some patients are coming much earlier. All these patients, especially to stamp them as a gender incongruence, we need to have a normal testosterone or estradiol according to their cisgender levels, as well as their karyotype should be normal as well. Though karyotype is not mandatory, but would prefer doing one before going for therapy. Again, though now it's improving, the family support is very poor. Only 11% have family support, and that's why a lot of these, because of lack of access, there is a lot of unplanned, ill-timed surgeries, and a lot of the patients present to us with already where they have done a mastectomy or castration by an unqualified non-medical person as well. So that's something we need to be looking at. So we need to have individualized goals. So this is, we not all patients want to go for surgery whole hog. So that's very important as well. And some patients, we need to also address the individual concerns as well. The basic principle is to reduce the endogenous sex hormones, decrease the secondary sexual characters of the designated gender, and replace the exogenous hormone consistent with the gender identity. And again, there is, with regards to which level of testosterone or other investigations biochemical profile we need to compare with. Again, with regards to the other biochemical profile, with regards to testosterone and estrogen, it's quite simple. We need to compare with the gender which the person identifies with, but with other hormones, it's actually midway. And also with regards to the biochemical reports as well. So most have a very high satisfaction rate, but the regret is there in about 1% of patients. So very important is, before we embark on therapy, we need to establish goal, evaluate the cardiometabolic risk, the thrombosis risk, and also address and treat medical conditions prior to treatment. We need to offset, the very high expectation, and they want very quick results, and that's why the dose is often, they self-administer higher doses. Important to discuss fertility before we start treatment, limitations and adverse effects, and also once we have started treatment, we need to monitor for adverse effects as well. So what are the situations? One is, most patients would now be coming for hormone therapy when they have not had any other hormone therapy or surgery. But we have patients who have taken illicit hormone therapy, then what is known as bridging. In children and adolescents, in a lot of people come in after 40, 50, around even 50. I have had 45, 46 years old patient, and also those who have already had surgery, which I was mentioning, and also patients who did not have surgery, who had surgery without proper hormone therapy as well. With regards to bridging, this is basically, most people come with illicit unsupervised hormone therapy. We need to do baseline investigation and rule out adverse events, assess current regime. Most of it is not very scientific, and we need to have a safe regime. Most of the doses are pretty high, and substitute safer alternatives, and also clearly mention the limits of therapy. Excessive doses are an absolute no-no. With regards to patients who have already undergone surgery, it's pretty simple, especially who have undergone gonadectomy. In trans female, we go for only estrogen, no requirement of GnRH or anti-androgens, whereas in trans masculine, only testosterone is sufficient. So baseline gonadal hormones, that's must. By CBC, biochemical profile, liver function, lipid profile has to be done. So that's very important. We should always do the baseline. BMD is not something which we do routinely unless it is indicated. If there are high risk factors, or the patients have, like patients who have already had gonadectomy, there we cannot go for, we need to do a BMD at baseline, already had a gonadectomy for some time. Again, we need to evaluate conditions and treat medical conditions that may be exaggerated by hormone depletion or hormone treatment, like testosterone therapy is contraindicated in polycythemia, estrogen in thrombosis. Testosterone can increase the hematocrit. Estradiol, especially, is poorly metabolized in liver impairment, and also oral testosterone should not be given in such situations. There can be dyslipidemia associated with testosterone therapy. Estrogen may worsen insulin resistance. DMD, especially in patients who have risk factors, who have not been treated properly in spite of having undergone gonadectomy, and have been treated at subtherapeutic hormonal replacement ranges as well. Electrolytes, especially if the patients are on spironolactone. So generally, the medications take 3 months time to have its effect, and full effect comes in about 2 to 3 years and depends on the dose and route of administration. For most of our patients, they are on oral estradiol for male to female, and you can see the equivalence of oral estradiol varenicline versus conjugated estrogen. Some of them, especially those who have higher risk, would be on transdermal, but very few because of the hot climate. Few of them are on injectable estradiol as well, but the availability is not that great. The anti-androgens and GnRH are required in male to female because only estrogens cannot suppress the androgen level. So it is generally ideal is GnRH, but most cannot afford. So we need to go with spironolactone or sapropterin acetate. And especially with GnRH, the dose requirement decreases and the side effects are also less. So for resource poor setting, we generally go for anti-androgens along with estrogen. For those who can afford, we go for GnRH therapy. Very important with regards to estradiol valerate, the advantage is it can be monitored both oral and injectable, whereas with conjugated estrogen and ethylene estradiol, we cannot monitor, and risk of VTE, venous thromboembolism, are higher. With transdermal preparation and injectables, the risk is actually lower. So we have seen that, with estrogen, majority of our patients take oral estrogen, and in combination with spironolactone anti-androgens, about 20% could afford GnRH therapy, and especially in those, the dose requirement was lower, and about 25% undergo surgery. So it's not all who would like to go for surgery, and especially about 40% would go for mastectomy. With regards to female to male, again, commonest therapy is testosterone enanthate every 2 weeks. We also give nowadays some preparation which can be given subcutaneous. Undecanoate can be given 1000 milligram every 12 weeks. Gel, especially who have problems with polycythemia, we can give gels as well. So standard dose is basically what is given in androgen deficient hypogonadal state. The targets are better achieved with parenteral therapy. Subcutaneous may maintain a better levels, less fluctuations as well. Some people do not have menstrual cessation with testosterone. There we require medroxyprogesterone or GnRH therapy. So for most of our patients, which we published as well in female to male, testosterone esters are preferred by 72% because they are most affordable. About 20% prefer undecanoate. Only couple of the patients chose gel as well. And most common surgery, as you can see, is mastectomy. About only 40% go for THBSO. So we are also aware of the targets. It's generally the cisgender target, whichever the gender the patient identifies with. For male to female, the target testosterone is less than 55. Estradiol is between 100 to 200. But we can monitor the estradiol only with transdermal oral valerate preparation, but not with conjugated or synthetic estrogens. For testosterone, the target is simple, 300 to 1000 nanograms per DL. For enanthate or sapanoate, we generally measure midway. For undecanoate, if we measure the trough, it should be below 400. For transdermal, after 1 week, we can measure at least 2 hours after application. So where it is contraindicated and the side effects, especially in transgender female, the high risk is of thromboembolic disorder, but prolactin rise, and also cardiovascular risk as well as cholelithiasis has to be assessed, and hypertriglyceridemia. In transgender male with testosterone therapy, there is a high risk of erythrocytosis, hypertension, dyslipidemia, and breast and uterine cancer. But very important, what is very common is the supraphysiological doses, which is so commonly used by a lot of these patients. We must tell them the timeline of progression with regards to appearance of changes, which takes about 3 months. Even for the periods to stop, it takes average about 6 months. In female to male, there is no RCT with regards to any hormone therapy, but most changes take about 2 years to occur. Again, with regards to facial hair, body hair, and muscle strength, they may not get adequate amount of development as well. So with regards to body fat distribution and hair distribution, it takes more time, and some of the changes are likely to be irreversible as well. That is something we need to impress before they embark on therapy as well. Again, what we have seen is that the main breast development, this has been reported as well previously, that occurs within the first 6 months to 1 year, and the estradiol level not always predicts the development of breast. With regards to female to male, again, facial and body hair growth is something, and scalp hair loss are highly dependent on age and inheritance, and muscle strength is again also dependent on amount of exercise as well. So these are the side effects for which we should be monitoring, especially in the first year every 3 months, and then at least twice a year. For feminizing therapy, we should actually be monitoring potassium, risk factors assessment, hypertension, dyslipidemia, body weight, prolactin, as well as assessment for cholelithiasis. For masculinizing therapy, polycythemia assessment and dyslipidemia, osteoporosis, and obstructive sleep apnea with testosterone is a relative contraindication. Now, liver dysfunction has been removed by Endocrine Society guidelines for monitoring in case of masculinizing therapy. As one ages, we need to decrease the doses and go for safer options. So when do we stop the gender affirmative hormone therapy? Especially, it should be stopped immediately with estrogen if there is venous thromboembolic event, if there is an estrogen sensitive neoplasm, or end stage chronic liver disease. And hypertriglyceridemia is a relative contraindication. For testosterone in female, very important to understand that testosterone may not provide adequate contraception. So pregnancy is an absolute contraindication. Unstable CAD, polycythemia, especially if it is more than 55, and history again of a breast or any estrogen dependent cancer. Obstructive sleep apnea is a relative contraindication. Now, with regards to feminizing hormone therapy, it is gradually up titrated, and we require anti-androgens and GnRH because only estrogen cannot suppress the endogenous testosterone. Very important, the risk factors for venous thromboembolism, which is common in the first year, are smoking, more than 40 years in obese patients and patients with a family history and comorbidities. Thrombophilia screening, however, should only be done if there is a personal or family history. And in such cases, we need to specifically avoid ethylene estradiol and conjugated estrogens, which we are now no longer using. We used to use 12 years back when we start, 12, 15 years back when we started our treatment. Now, we generally prefer estradiol valerate or sometimes transdermal where there is a high thrombotic risk. And again, there can be 20% increase in prolactin. So we can monitor prolactin baseline and annually. With regards to anti-androgens, spironolactone and cyproterone acetate are both effective, but generally we use spironolactone. And again, in some cases, we need to, however, monitor for blood pressure as well as potassium levels, but lower doses generally is not much of a problem. We also use the 5-alpha reductase inhibitors. They have some effects with regards to scalp hair loss, body hair growth as well, but they may be associated with mood alteration as well. Now, with regards to GnRH therapy, we use the 3-monthly more often because it's more convenient, and there can be initial rise in the levels after 10 days, and it is very effective also to suppress the facial hair and decrease testicular volume, and also in female to male, especially it can stop menses where for at least for some time till we achieve the proper testosterone doses. Again, if we are using a proper protocol, the BMD is not really affected by use of GnRH as well. And especially in children, GnRH is the only option for majority. So GnRH for male to female, it needs to be continued till gonadectomy, or if it is gonadectomy is not done for indefinitely. With regards to female to male, it is only used in small subset of patients where there is persistent uterine bleeding till the adult testosterone dose is achieved. So in female to male, it's much rarely used. So what should be the target, especially in male to female? First year we evaluate 3 monthly, then 6 to 12 monthly, monitor weight, BP, LFT, lipids. Especially, we need to monitor the excessive estrogen doses, which can cause liver dysfunction, hypertension, BT risk. Spironolactone, especially, we need to monitor potassium 3 monthly. Estrogen, especially, we need to be careful with regards to chronic liver disease because there can be a lot of alcohol abuse in these subsets of patients. Routine cancer screening, again, for breast and prostate cancer and hormone-sensitive, estrogen hormone-sensitive neoplasm. And also prolactin and triglycerides should be monitored both before and after starting therapy. There is absolutely a lot of patients would pester us for progestogens, though there is no good data with whether regards to benefit or harm. It may be used medroxyprogesterone for menstrual cessation in female to male, but there is higher risk of VT, weight changes, and lipid disorders as well. Micronized progesterone may be a better option. And there was one small study which showed a lower testosterone level and better breast development, but it is still not a standard of practice and not recommended routinely. For masculinizing hormone therapy, again, standard doses what we use for androgen deficiency achieves target, and sometimes that can be better achieved with parenteral therapy, and subcutaneous therapy now is coming up as well. Menstrual cessation generally occurs within first 6 months. And very important is that, that erythrocytosis is something which we need to be careful, and we need to monitor for with CBC first 3 monthly, lipid profile, blood pressure, weight. LFT is not routinely required. Estradiol monitoring is not routinely required in this subset of patients. Testosterone target is about 400 to 700 nanograms per DL, and especially higher doses of testosterone can cause erythrocytosis, sleep apnea, hypertension because of salt retention, and lipid changes, and cystic acne. And here we need to compare the hemoglobin and hematocrit with the male range as well. Serious hepatotoxicity is not associated, so it's no longer liver function is recommended to be monitored, especially when we are not using oral testosterone therapy. And screening for osteoporosis only in patients who have a high risk of bone loss. So erythrocytosis occurs in about 10% of patients. It is dose dependent, most commonly seen in first year, and we have had one patient having central venous sinus thrombosis with use of intramuscular andecanoate as well. Tobacco use, age, higher BMI increases the risk as well. If there is hematocrit is raised, we first try to decrease the dose, increase the dose interval, and sometimes transdermal testosterone gels may be a better option as well. Along with that, we need to emphasize on losing weight, stopping smoking, and optimizing COPD. So this is the case I was referring to with central venous sinus thrombosis with testosterone andecanoate as well. With regards to cancer monitoring, transgender male cervical cancer screening, especially if tissue is present, breast cancer screening, especially with mammograms if there is no mastectomy done. But if mastectomy done, sub and periareolar annual breast examination should be done. So routine screening as per in non-transgender individual, and all the tissues which are present. Ovarian cancer is reported, especially uterus is still there, and uterine cancer is not common. With regards to transgender female, again, breast cancer screening as per cisgender guidelines, very important to remember. Prostate cancer, especially, though rare, we need to be cautious, especially after the age of 50 years. With regards to bone health, again, there is no increased risk of osteoporosis with gender-affirmative hormone therapy, and there is insufficient evidence to recommend routine BMD. So it is only recommended if there is inadequate dosage, discontinuation, and also there is surgery without gender affirmative hormone therapy. So that's very important in high patients. Otherwise, in high osteoporotic fracture risk, it should be evaluated every 3 months. FRAX, again, we should be using both female and male calculator and taking the intermediate value for assessment of FAST. Prolactin, again, there can be estrogen therapy with transgender female. They can increase growth of pituitary lactotropes. There can be about 20% patients can show about an enlargement of prolactin by pituitary gland. And we must also be careful with regards to the assessment of the antipsychotic drugs, which are so commonly used, which may raise the prolactin levels as well. If you look at the BMI, the body composition of subjects, that is midway between the cisgender and transgender. For a transgender male, it is midway between cisgender male and cisgender female. So that's very important to remember. Estrogen, again, there have been studies to show worsens insulin resistance, but not so with testosterone therapy. With regards to ischemic heart disease and cerebrovascular disease, some increased risk with in transgender female, and however not seen in transgender male, though there is higher prevalence of dyslipidemia in transgender male. And venous thromboembolism is a big concern in transgender male, though we see it rarely as well. And weight gain also we need to address, and substance abuse is something which should be addressed as well. This is a medium-term, short-term prospective multi-center study studying the efficacy and safety of gender affirmative hormone therapy, which found that they are effective in inducing body changes and overall safe. In male to female, the increase in prolactin is most common abnormality which we detect. In female to male, it's acne, erythrocytosis, and unfavorable lipids are most common. The short-term and medium-term cardiovascular data are reasonably safe, but we still lack data on mortality and cardiovascular and oncology outcome. So this is the ENIG study which has been extended for 10 years. With regards to long-term therapy, especially maintenance doses, we need to lower the dose. We need to change to more safer formulation like transdermal formulation, and with aging also we need to change therapy as well. And also there should be reduction in doses as well. With children, generally we go for GnRH agonist therapy at TANF stage 2, because before that we should be differentiating between persisters and desisters as well. Shouldn't be using testosterone or estrogen. The alternative to GnRH is medroxyprogesterone, but it's not that effective. Again, there is no change in aerial BMD within 2 years of GnRH use. And when we are using pubertal induction in children, again, that should be done slowly after GnRH therapy as well. Fertility preservation is very important. Fertility counseling should also start before initiation of GnRH. Sperm preservation we need to discuss, as well as very important to discuss that testosterone does not always prevent ovulation. So discuss contraception as well. So before surgery, especially for male to female, we stop the estrogen because of increased risk of VTE, especially before bottom surgery, till the patient is mobile. After that, generally we stop. Post-surgery, we stop GnRH and spironolactone and only continue with lower doses of estrogen. Especially lower doses may also be required after breast augmentation. For female to male, generally testosterone may not be stopped because there can be reversal of menses as well, but we need to be careful about erythrocytosis and dyslipidemia. So in conclusion, gender identity disorder has to be evaluated in a stepwise fashion. It should be treated in a protocol-based multidisciplinary teamwork, where we need to involve the psychiatrists, as well as the psychologists, the surgeons. Hormone therapy, we need to check the eligibility criteria, the diagnosis, monitor for adverse events. Generally, gender affirmative therapy is safe and effective to maintain the sex hormone within the normal range of the affirmed gender, improves quality of life and psychological functioning. So should not be delaying therapy, otherwise that can lead to suicide. But we need to inform the patient the expected time of effects, the irreversibility of changes, need to clearly state the fertility prospects and fertility preservation options. Very important to monitor for complications, cardiovascular disease, cancer risk, and as one ages, one needs to adjust the regimen, the dose, as well as route, and especially prior to surgery, we need to discontinue therapy, especially in male to female, and restart post-operatively, but at a lower dose it is required. But in male to female, especially the GnRH and anti-androgens may not be required. So it's something which is a lot of people think that after surgery it's the end of there is no other interaction which is required. So we must emphasize it is a long-term, chronic, continuous therapy which requires continuous evaluation, dose adjustment, and involvement of psychiatrists as well as surgeons and bone health professionals as well. And so most of the healthcare, especially, we need to be talking about equality, And also we need to be empathetic towards this population of subjects as well. And it has to be treatment across lifespan. Thank you. Thank you for a
Thank you, sir. So I invite everyone for any questions. So, Dev Malia sir, like when they come to us first time, sometimes they want to hide this from the society, and they're like they don't want to talk to their parents, and their parents come to second or third visit. So how to handle those kind of situation? Because at the end,
So,
their family will come to know.
So what used to happen, I would suggest, I was mentioning in our published studies that about 12, 15 years back, only 10% had family support. And about when the family members used to come, the parents especially, they used to insist, try to emphasize towards us that, try to convince the patient otherwise, which is absolutely something which should not be done. That is what we should never be trying to convince otherwise. And but nowadays there is a change in societal attitude as well. So most of the parents, and they are more acceptable as well with regards to the situation. But once they come, and especially they do, as you just rightly mentioned, they come after second or third visit, when they have to accept the situation, they have no other alternative. Then they are mainly concerned about the safety of the subjects. So we need to actually tell them that the hormone therapy is safe if it is done properly and if it is evaluated properly as well as monitored. The problem is that with the transgender population is that they are a very closed community and very close communication. So a lot of times they would self-medicate, self-treat, and that would lead to supraphysiological doses. They wouldn't be monitoring. So that is where all the harm is done. A lot of these patients do not come back for regular follow-up, and especially once they go out for surgery, especially the bottom surgery, they think that the treatment is over. So we have to emphasize, especially, a lot of patients, they have done their surgery, coming back after 4-5 years, they have severely decreased BMD. So they don't, they're basically agonadal almost. And that's why we need to emphasize that the regularity of follow-up is imperative. They have to have regular medication, and most importantly, the dosage should not be increased without prescription.
So as you said, they are very closed and communicating community. Like they communicate, they share their prescription, where to get surgery and all those things. So like I in my practice feel that after completion of maybe 1 year or two, they lost to the follow-up. And though we have explained, that time there is no way to trace them. Like you see, many of them are coming back after a few years with some particular complications. Or like in your practice, what kind of follow-up you get after like 4-5 years?
Well, what happens is they would be coming back probably once or twice a year. That is the average follow-up after a couple of years. That is the most realistic, and especially after surgery. But must say again that with regards to complications, venous thromboembolism, especially in transgender male to female, I haven't seen a single case. The only thrombem was with the undecanoate preparation, which I just mentioned, was with a central venous sinus thrombosis, which I faced early on with one patient, and that too, because we don't really know, because the erythrocytosis also was not there. We used undecanoate preparation, but nowadays I don't. But there is a higher risk of in the long term of obesity, metabolic syndrome, dyslipidemia, diabetes. So these are lifestyle problems which are more common in these group of subjects. Substance abuse is something which is very, very common. We still do not it's most of my patients will be coming back for about 12 to 15 years after follow-up, longest follow-up. So still haven't had significant history of cardiovascular disease as well. But osteoporosis, again, once there is discontinuation of therapy, we have seen a couple of patients with fractures. One patient turned up with fracture, and especially patients who have been started late. We have had a transgender person, especially in the community, who just came, brought a person in the community who was not treated even at the age of 45. So that patient had a severe osteoporosis, and so those are issues which we need to be careful, especially lifestyle disorders, cardiovascular disease, osteoporosis. These are more important, and substance abuse. With regards to malignancies and cancers, again, a routine follow-up is necessary after a certain age as well, especially with regards to breast evaluation is something you need to be, because they are very, very, both transgender male and female are very sensitive about that issue. But a regular breast examination, even if we cannot do, should be done. And in patients who haven't done mastectomy, should undergo mammography as well. So that is very important as well for cancer, from the cancer perspective.
Like after long-term follow-up, maybe like 15, 20 years, do you feel like some of them are actually dissatisfied of their decision, like it was actually bad, like if some group of that?
Well, I would say I have the only people who the people who are actually dissatisfied are basically they actually identify that quite quickly within a couple of years, 1 year or so. So those 3-4 patients who have actually turned back actually are early on. In long term, there are very few dissatisfied people. They don't regret their decision. They may regret, what they regret is the adequacy of their treatment. So they would like to be, mind you, they would like to identify themselves as like a male. Transgender male would want to be like just like a male, and a female would like to be just like a female. So when we cannot achieve those targets, so especially in transgender male with surgery, the outcomes are not perfect. We have to be realistic about that compared to a transgender female. So their dissatisfaction is there, but they do not regret their decision. Those few people who actually go back on their decision are basically early on, and this is more common. That's why we need to be very careful in children before we stamp them as transgender, because there are a lot of these 80% will be desisters, only 20% will be persisters. So that is something which we need to commonly recognize during the pubertal stage.
As you rightly said, that the female to male, they will be having like erectile dysfunction and all these issues, because they assume that they'll be like sexually very active in the future. And do you also get demand of like something like penile transplantation and all those things in future in these group?
Yes, we get a demand for penile transplantation in a lot of these patients, and so that is an area where even after penile transplantation, the surgical outcomes are not. We may maintain their hormonal levels, but the surgical outcomes they are not. They have a very high expectation. Even when we are starting treatment with medication, they expect the changes to occur overnight. So I also try to tell them that with normal puberty, it takes time. So for even if you give the hormonal changes, it takes time, and that's why you have better development. Similarly, there are very high expectations with regards to surgery as well. And that is something we must always counsel them with regards to the expectation and reality. So that is also probably we need to have a word with the surgical colleagues and interact with them with regards to what they are going to expect after bottom surgery in the transgender male. In transgender female, the satisfaction rate is relatively good, especially the expectation and the outcome and satisfaction in a lot of patients are pretty good. But the problem is with transgender male post-surgery.
Thank you, sir, for answering all these questions with your experience and with the guidelines also. So this will really help all of us.
Thank you.
So I think we can move ahead with the next session. Mayur, can we go with Dr. Sambit Das session as Dr. Ajay? Hello.
Yeah. We can just move. We can skip the next session of gynecomastia. Dr. Ajay Agrawal is not available. We'll go androgen deficiency in aging male with Dr. Sambit Das, sir. So technically, please throw the CV. Yes, so Dr. Sambit Das need no introduction. He is DM from PGI FACE, Professor Department of Endocrinology at Bhubaneswar, Senior Consultant at Apollo, various publication in national and international journal, author of many textbooks including API, RSSDI, ESI, and principal investigator of many phase 3 trials. So without wasting much time, the stage is yours, sir.
Thank you, Dr. Mayur. So let me first share my slide. Hope it's visible and I'm audible.
Yes, sir. Perfect.
So thank you, Dr. Mayur, and the organizers, Dr. Ajay, for the kind invitation. So after a very nice talk by Devamalya Da, I'll be speaking on androgen deficiency in aging male. Sometimes we call it as ADAM. So yeah. So I'll start with a case scenario, basically a very common garden variety of patient which comes to in our clinical practice day in and day out. So a 62-year-old male with chief complaint of lack of energy, easy fatigability and lack of concentration. On detailed probing, he complains of decreased libido and erectile dysfunction for the last 1 year. Medical history, he's having diabetes for the last 5 years, hypertension for the last 5 years, and there is dyslipidemia. Drug history, patient is on metformin, DP4, telmisartan, and statin. On examination, he is obese with BMI of 33 kg per meter square with a waist circumference of around 110 centimeter. And other examinations with relatively normal. Laboratory workup, the HbA1c was 7.5%, no other complications. Serum testosterone when the patient had done advised by someone, so it has come out to be 186 nanograms per deciliter. And basing on that, usually we don't examine the testicular volume and pubic hair and all the Tanner stages in patients with diabetes and all patients of diabetes, but basing on the symptoms, the low testosterone level, and the examination revealed the testicular volume was 18 ml bilaterally, pubic hair is Tanner stage 5, and there was no gynecomastia. Then we did, since the testosterone was 186 nanograms per deciliter, which was lower, so the LH-FSH was also advised. It was 4 and 6 LH and FSH, and the thyroid function test and the prolactin levels were normal. So this is a case which many times comes to our OPD. Sometimes they come with the testosterone report with a lot of labs doing all sorts of evaluation. So the questions now is, there are 4 questions. Do we need to evaluate for androgen deficiency in this patient? Which tests are to be ordered? Do we need to treat this person or not? And what therapy should we offer? So these are the 4 important questions which I'll be answering in my subsequent presentation. So what is a male hypogonadism? So hypogonadism or testosterone deficiency is basically is a clinical and biochemical syndrome characterized by low levels of testosterone with associated signs and symptoms. It's not only a biochemical entity, but we have to have a supportive signs and symptoms to diagnose as a case of male hypogonadism. Sorry. Sorry, some slide problem is there. Is my slide visible? Yeah, hopefully it's now visible. So the male hypogonadism is actually a testosterone deficiency, is a clinical and biochemical syndrome characterized by low levels of testosterone with associated signs and symptoms. And this is the androgen deficiency in aging male. The study has been done by EMAS, or the European Male Aging Study, where they have shown that 20% of men in their 60s and 50% of men in their 80s have serum testosterone level, which is significantly below those of the young men. So that shows the androgen deficiency in aging male is quite prevalent in our clinical scenarios. The ADAM has, or the androgen deficiency in aging male have been, there are various terminologies for the same condition, like late onset hypogonadism or LOH, the androgen deficiency in aging male, or ADAM, the partial androgen deficiency in the aging male, sometimes called as p-ADAM, testosterone deficiency syndrome or TDS, and andropause. So it has been variously described, but the condition is same only. And the common symptoms of hypogonadism, basically, if for a male, it depends on at what age the hypogonadism has developed. For example, whether it is before puberty or after puberty. So if the hypogonadism is before puberty, we see failure to initiation of pubertal changes, incomplete pubertal changes. Patient may have gynecomastia, eunuchoidal body proportion, that means the long-limbed or the lower part or the lower limbs are longer than the body proportion, male sexual dysfunction, and infertility. So these are if the hypogonadism develops before puberty. But we are discussing a condition where the hypogonadism is developing after puberty, and what are the characteristic clinical features? There would be some regression of secondary sexual characters, may not be very much evident, like decrease in the pubic hair, decrease in the saving frequency, which is a very important and common symptoms. If we ask, then the patient can actually tell us, that is, the saving frequency has reduced. Change in body contour, decrease in the muscle mass, gynecomastia, psychocognitive like hot flushes, loss of concentration, change in mood, and male sexual dysfunction, like both decrease in libido and erectile dysfunction, are very common in patients who develop hypogonadism post-pubertally or in the adult onset. Signs and symptoms of hypogonadism is adults, just to again enumerate: poor secondary sexual characteristic, infertility, muscle wasting. In our patient, he had decreased libido, impaired erectile function, muscle weakness, increased adiposity, and decreased vitality. So these are some of the symptoms of adult hypogonadism. For our patient, do we need to evaluate for androgen deficiency? I think the answer should be yes, because the patient has definitely symptoms of hypogonadism, and as I have told, 5 out of 8 symptoms were present. So what does the recommendation tell us? This is the ADA Standard of Care 2022. It recommends that in men with diabetes who have symptoms or signs of hypogonadism, such as decreased sexual desire or activity and signs of erectile dysfunction, consider screening with a morning serum testosterone level. So that's the recommendation by the ADA. Now, how do we classify hypogonadism? Hypogonadism can be either a primary hypogonadism or it can be secondary hypogonadism. So this is the GnRH, LHFSH, testosterone axis. I think all of us know that. Now hypothalamus actually secretes GnRH. GnRH acts on the anterior pituitary to secrete LH and FSH. LH and FSH in turn act on the testis to produce testosterone or spermatogenesis. And in turn, they have a negative feedback to the whole system that we all know. Now, if testis is at fault, we call it as primary hypogonadism, so that the testosterone is low and the LH-FSH should be high. But once the hypothalamus pituitary is at defect, then the GnRH will be low, LH-FSH should be low, and the testosterone will also be low. So that is the difference between primary and secondary hypogonadism. We are discussing at present about androgen deficiency in aging male and diabetes. So probably we are dealing with a secondary hypogonadism. We are not dealing with primary hypogonadism, which affects the testis primarily. The causes of secondary hypogonadism, the acquired causes are pituitary dysfunction due to any cause, maybe tumor, surgery, trauma, infection, or infiltrative disorders. Hypothalamic dysfunction may be a craniopharyngioma or tumors. Hyperprolactinemia. Obesity can lead to secondary hypogonadism. Andropause, otherwise we are discussing right now, is ADAM. Some chronic illnesses like diabetes, hemochromatosis, CLD, CKD can lead to hypogonadism, secondary hypogonadism. Drugs such as corticosteroids, opioids, androgen, progestins, estrogen, and gonadotropin releasing hormone can also lead to hypogonadism. Malnutrition, wasting, or anorexia nervosa are other causes. Now, how frequently this ADAM actually occurs, especially in patients with diabetes? This is the epidemiology of male hypogonadism. Androgen deficiency increases with age in healthy men. And there is a study known as the HIM study where they found 38.7% of men above 45 years of age suffer from subnormal testosterone level. And Indian men, 20 to 48% prevalence in men above 40 years of age. So that is the prevalence of hypogonadism in male. Association of hypogonadism with obesity and diabetes, it's very closely related, and they have a strong crosstalks between obesity and diabetes and hypogonadism. Prevalence rate of hypogonadism is around 45 to 57% with coexistent obesity and diabetes. And 25 to 40% of patients who are diabetic can have some kind of secondary hypogonadism. This is the EMA study of more than 3,000 male. They found 73% of men with reduced testosterone were actually overweight or obese. And serum testosterone with BMI more than 30 kg per meter square was 144 nanograms per deciliter lower than for those with normal weight population. Low testosterone and diabetes, the meta-analysis, it's a 43 prospective and cross-sectional studies of 6,427 men for cases and controls. And what they found was that difference in testosterone level between diabetic and non-diabetic groups was actually significant. Men with higher total testosterone concentration had actually 42% lower risk of developing type 2 diabetes than in the lower testosterone concentration. And there is also another meta-analysis, which is a cohort, 13 cohort and nested case control study where they've taken 16,000 population, where the meta-analysis showed that higher total testosterone level was associated with decrease in the risk of type 2 diabetes in men. And this is the male hypogonadism associated with increased incidence of diabetes. You can see that men with low testosterone has almost like a 20 diabetes in a 9-year follow-up, around 20% of developing diabetes, and compared to men with normal testosterone or the total population. This is a study from India itself, the prevalence and correlation of the male hypogonadism with different diabetes duration and complication, where they found that the duration of diabetes, the more the duration of diabetes, the more chances of hypogonadism is there. And it has been associated with some complications like diabetic retinopathy, increase in the insulin use, and the higher the HbA1c level, the more is the hypogonadism. So what could have been the potential mechanism of hypogonadism in diabetes, obesity, and metabolic syndrome? So there might be many causes. One is the leptin resistance because of visceral adiposity, androgen receptor polymorphism, sex hormone binding globulin defect. So all these things can actually lead to hypogonadism. Role of leptin is very important because it has been shown that adequate amount of leptin and its effect on the hypothalamic kisspeptin neuron is essential to activate the kisspeptin, and kisspeptin finally will activate the GnRH and the LHFSH pulsatility. But what happens in hypertrophic or adipose tissue or with obesity is that there occurs leptin resistance, like insulin resistance, and there are other inflammatory cytokines. They actually suppress the kisspeptin level in the hypothalamic kisspeptin neurons, and that will reduce the GnRH and subsequently the LHFSH and testosterone secretion. Now, most clinical things we'll discuss right now. How do we evaluate a patient? How to make a correct diagnosis of hypogonadism? We must remember three important things. First, there should be signs and symptoms suggestive of hypogonadism. We must draw a sample of total testosterone at 8 a.m. morning fasting and levels below 300 nanograms per deciliter on 2 separate days. We can tell it as hypogonadism. So these are the Endocrine Society recommendation in 2018. The signs and symptoms: 8 a.m. cortisol, that should be less than 300 nanograms per deciliter. What are the clinical presentation of andropause or the ADAM? You will have decline in the cognitive function, depression, thinning of the hair, or baldness, reduced muscle mass, increased fat mass, reduced bone mass, testicular atrophy, decreased sexual desire, decreased libido, loss of elasticity and thinning of the skin, gynecomastia, and decline in the cognitive function. History taking and physical examination is very important, and we must take a comprehensive history, sexual history, past and present illness, patient complaints, and exposure to various drugs or addictive substances. That has to be clearly, a history should be properly taken. Physical examination, general examination, we can do including a blood pressure. Then body proportion is important, body mass index, waist circumference for obesity. Then we can do a genital examination like testis, the size, consistency, and the scrotum or the pigmentation. Secondary sexual characteristic like level of virilization, hair growth, beard growth, spermatic cord, and varicocele. So these are the examination and history part which we can do in a patient of suspected hypogonadism. What are the role of screening questionnaires? Now, there are very good screening questionnaires which have been adopted by various studies, and also we adopt in our clinical practice. One of them is ADAMS scoring system, that is the androgen deficiency in aging male questionnaire. Then there is Q-ADAM, the aging male survey, the Massachusetts male aging study, and the HISQ. And the sensitivity varies for different questionnaires. The questionnaire which we use in clinical practice is the ADAMS scoring. The sensitivity for ADAM is about 97%. For the MS, it is 83%, and MMAS is 60%. And the specificity was 30% for the ADAMS scoring system. So what test we should actually choose after the history and physical examination, whether we should do a total testosterone, free testosterone, or an SHBG or an LHFSH. Now, what test we have to do? It's also a controversy in that. But the global guidelines, if we say the American Urology, the British Society of Sexual Medicine, or the Endocrine Society, or the any other bigger societies, total testosterone has always been taken as a cutoff, not the free testosterone level. Conditions where free testosterone is recommended is when there is a decrease in the sex hormone binding globulin, like obesity, diabetes mellitus, glucocorticoids, some progestin and androgenic steroids, nephrotic syndrome, hypothyroidism, acromegaly, and SHBG gene polymorphism. So mostly obesity, diabetes, hypothyroidism all have decrease in the SHBG level. So you may have a low testosterone level. Increased SHBG is found in aging, HIV patients, cirrhosis and hepatitis, hyperthyroidism, estrogen, SHBG polymorphism, and borderline low total testosterone may be around lower limit of normal between 200 to 400. Sometimes we need to go for a free testosterone level. Now, what are the factors that influence the testosterone level? The factors depicted in this picture are two mostly. One is the age and the second is the BMI. You can see the red dots are actually BMI more than 30. The blue dots are actually BMI less than 25. And the x-axis denotes the age. And if you can see closely, then you can see that the testosterone level is actually a function of the BMI. So the higher the BMI, the lower is the testosterone level. And as the age passes, the testosterone level may remain normal, but the free testosterone actually goes down. And LHFSH starts increasing after 60 or 65 years of age significantly. Sorry. Hope my slide is visible now. Yeah. So what is the diurnal variation? So after telling the discussing about the age and the factors influencing the testosterone, there is also a diurnal variation for the testosterone. And if you see the diurnal variation in that, so the diurnal variation is most marked in a younger age group. For example, if you see 30, 40, 50, 60, 70, and 80, the diurnal variation is actually least with the elderly population compared to the younger population, and it would be in a nadir in the evening. So a morning 8 a.m. Testosterone is the best test that can be done. So what are the things to ensure for testing for testosterone level? It should be a fasting sample. It should be taken between 8 to 9 a.m., 8 to 10 a.m., and the patient should not be sick. So never ever evaluate a patient with hypogonadism in the hospital setup. So that many times mistakes are done by physicians or our other colleagues, but the patient should be absolutely stable before you evaluate the gonadal axis. So it should be fasting between 8 to 10 a.m. and the patient should not be sick. The diagnostic evaluation, if you see, then if you suspect a case of hypogonadism, check for a total testosterone level. If it is less than 200 nanograms per deciliter, you are dealing with an androgen deficiency. If it is more than 350 nanograms per deciliter, you are ruling out an androgen deficiency. If it is between 200 to 350 nanograms per deciliter, repeated total testosterone may be a later date or measure a free testosterone level. If free testosterone level is also low, then you are probably diagnosing a case of androgen deficiency where you have to do an LH level. If the LH is high, there is a primary gonadal failure, and you can think of the primary causes. If the LH is low or inappropriately normal, you can think of as secondary hypogonadism or hypogonadotropic hypogonadism. How do we manage the patient? Managing the patient, we have to ensure 4 or 5 important things. First, our target is to symptom improvement. Then the second is alleviate the signs, maintain the normal testosterone level, and ensure the musculoskeletal, cardiovascular, and the trichocutaneous health. Ensure no untoward side effects are present. So first, ensure that you are not doing harm to the patient. There are the testosterone trials, 7 coordinated trials in testosterone treatment in elderly men, almost like mean age of 72 years, 77, 88 males, and the testosterone treatment increased the median testosterone level from unequivocally low at baseline to the mid-normal level. So what they found was that after maintaining a adequate testosterone level, the sexual activity has increased. Slightly, the walking ability has improved. Vitality has not improved, but volume and bone mineral density has definitely improved. So the conclusion from this testosterone trial was that improved all aspects of sexual function, improvement in walking distance by a small amount, but did not improve the vitality, but slightly improved the mood, markedly increased the volumetric bone mineral density, and not associated with more cardiovascular and prostatic adverse events. There is a long-term testosterone therapy in type 2 diabetes associated with decreasing the waist circumference. And if you are continuing with that therapy, probably the waist circumference will go down. Otherwise, it will again revert back. Long-term testosterone therapy in type 2 diabetes is associated with reduced mortality without improvement in conventional cardiovascular risk factors. So these are another study which has shown about the Kaplan-Meier's curve of use of testosterone and the long-term therapy. And there are studies which have actually shown that probably the ×2 study, improvement in insulin resistance, lipid, body fat composition with the use of testosterone therapy in type 2 diabetes and metabolic syndrome. Another study of 4,030 patients with type 2 diabetes. There was hypogonadism where given testosterone therapy which reduced the HOMA-IR, glycosylated hemoglobin, and fasting plasma glucose level. But should we offer this therapy or not? So that is the main question. And that actually should have a patient preference. The safety issues, the efficacy, and the availability and cost are also very, very important. So with this controversy, what the Endocrine Society tells about the clinical guidelines of testosterone therapy is very clear-cut. Now in hypogonadal male between 55 to 70 years who are being considered for testosterone therapy and have a life expectancy of more than 10 years, they suggest that discuss the potential benefit and risk of evaluating the prostate cancer and prostate monitoring and engaging the patient in shared decision making. So if we are starting and there is hypogonadism between 55 to 70 years, we need to discuss with the patient. But they clearly tell that we suggest against routinely prescribing testosterone therapy to all men more than 65 years older with low testosterone concentration. Similarly, men with type 2 diabetes who have low testosterone concentration, we recommend against testosterone therapy as a means of improving the glycemic control. But if the patient has symptoms and there is definite hypogonadism features and the testosterone level is low, then you can discuss with the patient and can start the therapy. Counseling for testosterone therapy in midlife male by Dr. Kalra et al. And fortunately, I was part of that. We must discuss with the patient, and there is in water mnemonics how we can actually discuss. So welcome warmly. A is ask and assess. T is tell truthfully. E is explain with empathy. And R is reassurance and return the patient. And these are the different preparation currently available in the Indian market. Oral capsules, we have testosterone Ondeconet, 40 milligram 2 to 3 times a day. Percutaneous gel, testosterone 1% once daily. Intramuscular injection, we have testosterone suspension, which may be aqueous or esters like 100 or 250 milligram, which can be given every 3 to 4 weeks. Testosterone Ondeconet can be given in every 3 months. Before using testosterone, we must know what are the contraindication. Condition in which T administration should not be done if there is a metabolic prostate cancer or breast cancer. Moderate to high risk for adverse outcome if unevaluated prostate nodule or if the PSA is more than 4 or if it is more than 3 in high risk population. If the hematocrit is more than 48% or severe lower urinary tract symptoms or the LUT syndrome. Uncontrolled or poorly controlled congestive heart failure is also a adverse event, and desire for fertility in the near term is also a relative contraindication. Safety and monitoring, if you have started with testosterone, we must do a baseline testosterone, distal rectal examination, PSA and hematocrit. Every 3 monthly and annually we can follow, assess and implement the side effects, testosterone level, DRE, the PSA and the hematocrit. If osteoporosis, then we can do a DEXA scan. Now the last slide is that how do we approach with the testosterone therapy? For psychocognitive and medical and sexual health, if the symptoms is very severe, if the patient is willing to take injection, you can start with aqueous testosterone once or twice weekly. And if not willing for injection, we can start with the gel or high dose oral testosterone therapy. Mild symptoms or minimal distress, no immediate relief is needed, we can start with the oral testosterone BID or TID also. Then we need to review after 1 or 2 weeks. If there is a satisfactory improvement, discuss the advantages and limitations of preparation. If willing to take injection, better to switch over to intermediate or long-term intramuscular. Not willing for injection, maybe a gel or an oral testosterone. Unsatisfactory improvement, you may change the dose or you can stop it also. If the patient is not improving, why to give the patient with this sort of therapy? So summarizing, hypogonadism in aging male is a common condition and even higher prevalence when associated with type 2 diabetes and obesity. Thorough history, clinical examination, targeted investigation can cleanse the diagnosis. Optimal management should focus on symptomatic improvement, elevating the signs, maintaining the normal T level. Overall, biopsychosexual health should be given importance. Individualization of management is of paramount significance. So with that, I'll end. Thank you for the patient hearing.
Thank you very much, sir, for that talk. Few questions from the audience. Firstly, you have shown some study of free testosterone also in clinical practice, especially in India, how relevant it is to get free testosterone.
Yeah, I think that's a very important question because many times many physicians actually write a free testosterone without knowing the assay quality and the assay significance. In fact, in India, doing a free testosterone would be difficult because the LCMS and the other things mass spectrometry is not available, and that can actually give the proper value of free testosterone. And for all practical purpose, we can do a total testosterone, and that is only recommended.
Any role of free androgen index in males as well?
Yeah, free androgen index, it has got a role, and especially I have shown in one graph or one table where you have the SHBG which is varying. Maybe SHBG is high or SHBG is low, or there are borderline this thing. There you can use that.
Any other question from other speakers, delegates? You can just pour in your question in the chat box.
So, like Dr. Sambit sir, like SHBG is more important, I think, than free testosterone in Indian setting. Correlating that. That is what. Hello.
Hello.
So, like in our setting,
yeah,
this SHBG and testosterone is more important compared to the free testosterone.
Yeah, absolutely, absolutely.
Because they're very erratic.
Yeah, very erratic. So many times, in fact, that holds good for evaluation of PCOS also. So never ever advise for a free testosterone. So it's always a total testosterone. And if doubt, you can do an SHBG also.
Okay. One question from another delegate. Any role of stimulation test in this condition?
No, I think for what we are doing, it is a very clear-cut definition for hypogonadism. You should have signs and symptoms with a testosterone level that should be less than 300 nanograms per ml, or there are some condition, or there are some cutoff like 250. But we are not treating the biochemical entity. We have to see both the biochemical and the clinical signs and symptoms are present. So there is no role for stimulation for in hypogonadism or in adult onset hypogonadism patients.
Okay. So thank you very much for taking up all the questions and for such a wonderful detailed talk. And we also have a message from a delegate. This was very good and very basic understanding, especially from the physician point of view. So thank you very much.
Thank you.
So over to Dr. Shiven Verma. So can we have the CV slide of next speaker, please? Tech team.
Yeah, maybe just check whether my voice is my internet connection.
You can. Yeah, you are audible. You can just.
Yeah, am I audible?
Yeah, you are audible. Okay, I think some connection issue. I'll just introduce Dr. Viplav Bandyopadhyay. He is DM Endocrinology. He is presently working in Raipur, Chhattisgarh, President of Arogyam Prevention and Control Disease Society from 2016, organized first RSSDI in Chhattisgarh in 2015, published many scientific papers and is a speaker in various national and international conferences and is a principal investigator of various clinical trials, honored by Times of India as the best doctor in 2008, also honored by Economic Times in 2023, presently in New Delhi. So he would be speaking on ovulation induction, especially the newer aspects. So over to you, sir.
Yeah, thank you. I'm sharing my screen. Yes. Just a minute, I'm getting some technical problem.
हेल्प करना बेटा একটু বেঁচে গেছি আমি स्क्रीन शेयर नहीं कर पा रहा हूँ आना
इसमें से स्क्रीन शेयर नहीं कर पा रहा हूँ। इसमें है टॉपिक इसमें है, ये कहाँ से आएगा?
पहले इसको बंद करो।
बंद कर। हाँ उसको नहीं शेयर नहीं शेयर। Yeah, thank you very much. Sorry for the delay. Am I audible?
Yes, sir.
Yeah, thank you. So I will present today evening ovulation induction. So ovulation induction is a phenomena that we know that for infertility is very much important, and ovulation induction and controlled ovulation stimulation are the two words, and ovulation induction is pursued in patients who are not ovulating, and controlled ovulation in stimulation are done for the women who are already having ovulatory cycles but are still experiencing infertility. Both treatment incorporates many of the same medications. So female factor infertility, ovulation dysfunction, we know that 40% of the female factor of infertility is there, and regular menstrual cycles, as we know, and there can be thyroid dysfunction, hyperprolactinemia, or polycystic ovarian disease that can be responsible for ovulatory dysfunction. And we know the hypothalamus, pituitary, and ovarian axis. Hypothalamus secretes the GnRH, and the gonadotropin releasing hormone is secreted, and pituitary secretes LH and FSH, and that ultimately with the estrogen and progesterone regulates the normal menstrual cycle. So methods are available to further define the ovulatory function. Basal body temperature rise during ovulation from 0.3 to 0.6 degrees Celsius is important, and a positive test for ovulation can be measured by measuring the LH level of the urine. And ovulation is may be associated with hyperprolactinemia and treated with the oral dopamine agonists such as cabergoline, and prolactin level should normalize after 4 weeks of treatment, and most patients and 80% report successful ovulation once this occurs. So this is the job of endocrinologist to treat up to this level, and assessment of the ovarian reserve can be done with the AMH level, anti-Mullerian hormone, and can be done with FSH. The normal level of the AMH up to 25 years old is 3 nanogram per ml. 30 years old, it is 2.5 nanogram per ml. 35 years old, 1.5 nanogram per ml. And 40 years older and above is 1 nanogram per ml. So measurement of the basal level of the serum FSH and estradiol on day 3 of the cycle will suggest that what is the ovarian reserve, and high FSH more than 10 and high estradiol level suggest low ovarian reserve. So this assessment has to be done before ovulation induction. And impaired cervical mucus is sometimes a problem in infertility. Treatment with mucolytic agent like guaifenesin has been tried, but may not be successful. Second is male factor infertility, which is again 40% responsible for this, and 20% of the infertility are of unknown factors. So impaired sperm production by testicular trauma or cryptorchidism, radiation exposure, anti-estrogen medication taken, anti-androgen, and varicocele of the scrotum, it can be responsible factors. And sperm transport defects can be there where there is blockade of the vas deferens, and some medications like antidepressant, antihypertensive can be a responsible function for infertility. Most important thing is the weight. Weight is metabolic syndrome is an important factor of elevated estrogen and lower testosterone level. So after male factor infertility, as we know, the normal ovulation induction, and our target is to achieve a single dominant follicle. And we know the different phases of the menstrual cycle, the follicular phase and the secretory phase. And when the hormone levels LH, FSH, LS surge is there when the follicle comes out of the ova, and the level of progesterone rises during this period. And if pregnancy is there, that means the combination of the ova and the sperm takes place, then the progesterone level further rises. Otherwise, the corpus luteum is degenerated with time. Assisted reproductive technology can help when there is need for ovulation induction. In assisted reproductive technology, 37% resulted in pregnancy and 30% in a live birth. But in countries like Israel, the ovulation and pregnancy level after 3 cycle, it is 54%, and after 8 cycle, it is 84%, very much successful. Average in India, about 40% chance is there to get a pregnancy with the assisted reproductive technology. Infants born from the multiple gestation pregnancies, which make up approximately 30% of the pregnancies from ART, and many experience health complications as a result of the preterm birth and low birth weight. Infertility itself has been linked to an increased risk of birth defects. Sorry for the problem. Because it is raining here and therefore the communication may not be proper.
It's okay, sir. Take your time.
Yeah, please.
Is it possible for the tech team to take care of the slides if they have the PPTs?
No, I have not sent the PPTs to them. See if I can go back and then again.
Yes, sir. Your slides are back.
Yeah, I'm trying to. They're not moving actually.
If possible, you can
So try presenting in a normal mode rather than a presentation mode.
Right.
I believe we could see your slides then.
Yes, yes.
Recording in progress.
I will rather read the slides, and I'm using my mobile phone. Sorry for the delay. Yes, I will go slide the normal presentation. So I will only, you will not be able to see the slides. An evolution associated with the hyperprolactinemia I have already discussed, and cabergoline therapy. And the ovarian reserve I have talked with, male infertility and assisted reproductive technology. The procedures are adopted by the infertility specialist are ICSI, that is intracytoplasmic sperm injection, and gamete intrafallopian transfer. That means the retrieved oocytes are transferred with the sperm to the fallopian tube to allow the natural fertilization, and zygote intrapolyfallopian transfer, in which the zygote is transferred directly near the fallopian tube. And this results in slightly lower birth weight, live birth rate than the IVF. So ovarian induction is the choice of medicines. Ovarian induction is dictated by the hypothalamic pituitary ovarian function. With adequate hypothalamic function, and oral regime of the clomiphene citrate may be used as a first-line therapy that will stimulate the GnRH and pituitary gonadotropin and induce ovarian follicular development. And oral aromatase inhibitors like letrozole are not approved by US FDA, and that should not be used in our setup also. So clomiphene citrate is a molecule which causes competitive binding of the clomiphene to the estrogen receptors in the hypothalamic level and causes release of GnRH. And gonadotropin released from the anterior pituitary that leads to the follicular development and causes then ovulation. Clomiphene citrate is used for 50 milligrams once a day for 5 days. Some people use it earlier, 2 to 6 days or 2 to 5 days, but there is not much benefit of it. Ovulation typically occurs to the 12 days after the 5th dose of the clomiphene citrate taken. If ovulation documented but pregnancy does not occur, the same dose is continued for the next cycle. If ovulation does not occur, then the doses can be increased. One can go up to 150 milligrams if doses are not successful. Adverse effect of clomiphene, as we know that it causes vasomotor symptoms because of the GnRH, and headache, irritability, mood swing, and nausea can occur. And second is it can give rise to multiple births. Aromatase inhibitors, as I told you, that they are basically stops the conversion of androstenedione to estrone and testosterone to estradiol. So this way they act and they increase the GnRH level. In vitro fertilization, the controlled ovarian stimulation can be done with oral contraceptive initially, then GnRH agonist and GnRH antagonist can be used depending upon the experience and the laboratory which is working on it. And then gonadotropin is given FSH or FSH plus LH in different modules or different protocols. And then the oocyte is retrieved by giving SCG injections, 10,000 units, and the luteal phase continuation is done with progesterone. Ovulation induction by gonadotropin. If hypothalamic or pituitary dysfunction is detected, or if oral regimes are not successful, injectable gonadotropins are administered. Most common gonadotropin regime is FSH administered alone or in combination with LH. Step-up regime is protocol represents the natural progression of gonadotropin release during the menstrual cycle. Initial daily doses 50 to 75 international units are increased by 37.5 international units as necessary for follicular response. Step-down response is initial dose of higher dose of 150 international units, and then gradually the dose is reduced. Gonadotropin release hormones analogs undergo long protocol, which I will show in a picture, and initiated drug of follicle and the luteal phase in the preceding menstrual cycle. Once gonadotropins are initiated, the GnRH agonist is continued at half the daily dose until the ovulation is stimulated. If an oral contraceptive is used in the previous cycle or pre-treatment, the GnRH agonist is often initiated in the last week of the contraceptive regime. And usually the rebound phenomena, oral contraceptive is given, then the rebound phenomena, GnRH stimulation can be better. In short protocol, GnRH agonist is administered in the conjunction with the gonadotropin for the stimulated cycle. The long follicle, as I have discussed, in which the GnRH agonists are given throughout a pregnancy, throughout a menstrual period, and then up to the 10th day or 15th day of the menstrual cycle. And gonadotropin, FSH, is given from the 2 days, 3 days previous to the cycle and continued till the ovulation takes place, and then SCG is given. The long luteal phase is similar. When the luteal phase GnRH agonist and the gonadotropin is given. There are a lot of list of the agents which are available as GnRH gonadotropin as HMG or urinary follicular uropolytrine, and recombinant FSH levels are injections are also available, and they can be prescribed. The procedures, as you know, that when we stimulated ova and the laparoscopically or colposcopically, the ovas are retrieved from the ovary, and then in the test tube, they make the presence of sperm and ova on a petri dish to get fertilized, and the fertilized ova is placed inside the. So we have discussed protocols, long protocols, short protocols, and then the luteal phase support is given with progesterone, because progesterone is very much required during the luteal phase, and long-standing progesterone therapy is given unless up to a level of 3 to 4 months. And therefore, I cannot show you the summary of the it. So as we see, that summary is, first we can give a oral contraceptive therapy, and then the GnRH agonists are given for some period, and then for the stimulation period, the get it and fertilize it with ICSI, which is a popular technique nowadays for a better pregnancy. And when the fertilized zygote is then delivered into the female uterus, and they are placed there. So the role of endocrinologist is there, because we know that which patients may require which sort of medications, whether oral medications or further medications, but mostly it is in hand of the infertility specialist. And our understanding should be made with, should be there with the ovulation induction techniques. And some words about ovarian plasmapheresis. The PRP, the patient's blood is withdrawn, and then the platelets and the concentrate which we obtain, that is injected into the ova, so that those ovaries which are not making a lot of ovas, they can get back to it, and the ovulation can start again. In this way, a patient can undergo pregnancy without stimulation also. So the aging population, when the AMH level is very low and the ovulation is not taking place, the PRP injection inside the ovary can be successful sometimes. Thank you. Thank you for Kavas making a presentation. Thanks a lot for hearing me.
Yeah, thank you so much, sir. Although it was interrupted, but so nice to hear of you for after a long time. So just one quick question from my side.
Yes,
Do
sir.
the endocrinologists in current era can go ahead and instead of just doing evaluation for infertility, they can at least do this medical ovulation induction up to the level of letrozole or phenobarbital? Sir, am I audible? Sir, you are muted. Yes.
Sorry. Sorry.
Yes.
Yeah, we can go for clomiphene citrate induction up to 5 cycles or 6 cycles when the patient is poor and they cannot afford the costly IVF therapy. We can definitely help it. And if support is available with the gynecologist, then the intrauterine insemination can also be tried. And up to that level, a cheaper version of the artificial reproductive technology can be done by us. Probably you cannot go beyond that.
Yeah. And sir, what about metformin? Still for
Definitely, there are multiple trials that for the PCOD patients. For the PCOD patients, metformin is a good drug which can help in reducing the metabolic syndrome part of it, and that can give rise to some improvement in the ovulation. Definitely is a good drug.
Yeah. Okay. We still can have 1 or 2 questions if anybody can chip in and wants to ask sir anything about ovulation induction. And there is one more thing like myoinositol. Right now, so many people are using it. So, and I heard.
Yeah, myoinositol has got a lot of contraindication. Recent papers are showing that myoinositol is not good for a patient to be given because of its some birth defects, and there can be some genetic abnormalities in the patient. So after going the recent article, I have stopped using in PCOD patients also myoinositol, because it can do some genetic abnormalities or some change in the genes that can be there. But the companies are still asking to prescribe it.
Yeah, so I don't think so. Any more questions are there? I'm checking the.
I think Dr.
Talk on the. Yeah, and Mayur, you can take over from here. And good evening, Kalpana ma'am.
Yeah, hi. Good evening. Good evening, everyone. So, shall I share my screen now?
Just a minute, ma'am. Okay. First of all, thank you for accepting the invite. Tech team, can we have the CV? So there's some. Yeah. So Dr. Kalpana Dash, she is DM Endocrinology, again from Aron Institute, SGPGI, presently working with Apollo, Bilaspur, Chhattisgarh, Professor of Endocrinology. And she is also a senior consultant at Narayana Hrudayalaya, and she has various publications with membership of various organizations. She is actively involved in teaching too. So with that short introduction, over to you, ma'am. Thank you very much.
Yeah, thank you, Mayur. I'll just share my slides. Thoda help karo re, kaun sa? फिर से शेयर करो। पता नहीं, इसको खोल दूं क्या स्लाइड को? हाँ, कौन सा? Yeah, can you see my slides now?
Yes, ma'am, it is.
Okay.
Perfect. Just a minute.
Yeah. You can see now, no? Okay.
Yes.
Yeah, thank you so very much. Thank you, organizer, especially Mayur, for giving me this opportunity and to be a part of this symposium, the Hormone India. And thank you, Shivendra, for having me here. So I'll be talking on recent advances in the management of polycystic ovarian syndrome. So as everyone knows, polycystic ovarian syndrome is a polygenic and a multifactorial syndromic disorder, and it has its implication not only in reproduction, but also metabolism, dermatological diseases, general health, sexual health, neoplasia, and also quality of life. And it also has many unresolved questions. So any girl in our OPD, when she comes into our OPD, so we should first know, is she gaining weight rapidly, or is she troubled by any kind of facial hair, presence of acne, or presence of irregular cycles? Is she married and unable to conceive? Then she probably might be a victim of PCOS. So next time we should not criticize such kind of girls when they come into our room and asking for help. Rather, we should help the girl. So as you know, this condition is the most common endocrine disorder affecting in the during the reproductive age, and is the most frequent cause of infertility, and it is increasing also very fast with a very fast change in the lifestyle and also stress. And it is also very strongly associated with insulin resistance, is also risk factor for future diabetes mellitus, hypertension, CVD, dyslipidemia, endometrial cancer, breast cancer, recurrent pregnancy loss. And in most of the cases, the PCOS, 50% of the cases, they just need weight control. Losing just about 5% or by 5 to 10 kgs is having tremendous effect. So just defining PCOS, as you know, there are various criteria that we have to define PCOS. So that includes menstrual irregularities, presence of hyperandrogenism, and also presence of polycystic ovarian morphology in the ultrasonograph. WHO estimates about 116 million cases, about 3.4% are affected by PCOS worldwide. Heterogeneity does exist from etiology to clinical presentation, and it also has heterogeneity in long-term prognosis as well. You know, etiology is unknown. However, there are evidences that it is a complex disorder having strong epigenetic, genetic, familial, environmental influences that also includes diet and lifestyle issues. Treatment is always symptom-oriented, and of course, it is very much individualized. And therapeutic approaches I discussed later on. So, you know, this is a complex syndrome, as I said. So, on one hand, actually, the genetic, epigenetic, obesity, lifestyle, environmental, and neuroendocrine factors plays a role, especially in those genetically predisposed girls to the excess ovarian androgen secretion. And this causes the presence of development of polycystic ovary, and that causes increase in the testosterone level, that causes the clinical symptoms like alopecia, acne, and hirsutism. On the other hand, it is also supposed to be that there is dysregulated hypothalamic pituitary axis that leads to anomalous gonadotropin release, increases the LH-FSS ratio, and reduces the FSS. That causes also the increase in the LH level, causing anovulation, irregular menstruation, increased testosterone can cause increase in insulin resistance, hyperinsulin. All this leads to the syndrome complex. The recent 2018 ESHRE and ASRM evidence suggests that the pathogenesis, the polycystic ovarian syndrome, the hypothesis of PCOS as functional ovarian hyperandrogenism, that is 2/3 of the cases could be because of the typical familial ovarian hyperandrogenism that is normally characterized by 17-hydroxyprogesterone hyperresponsiveness to the gonadotropin stimulation, and rest 1/3 could be because of the increase in the testosterone after suppression of the adrenal androgen production, or it could be because of the isolated functional adrenal hyperandrogenism, or it just could be because of the mild and lack of evidence of steroid secretory abnormalities. So these are all the clinical features because of the dysregulation. It can cause menstrual irregularity because of chronic ovulation. It causes hyperandrogenism, causing acne vulgaris, hirsutism, alopecia, especially bitemporal hair loss, that is male pattern baldness, or presence of PCOS, overweight, and obesity leading to other metabolic complications in the future. And PCOS could be just the 30% cause for infertility that we see in our OPD. So this is one of the clinical parameters we know about the hirsutism. So we have to score the hirsutism just by using the tool that we call it as modified Ferryman-Galloway. This is the gold standard for the clinical evaluation of the hirsutism. So the scoring is done on 9 body regions. So the score is 0 to 4%, maximum is 36 and minimum is 8. It should be more than 8 for diagnosing hirsutism. Mild hirsutism means 8 to 15, moderate to severe is 15 to 24, and more than severe is 24. So this has to be categorized. That is because the management also depends on that. So areas, as you know, all endocrinologists must be knowing, but for the physician, so I just want to categorize the areas with the upper lip, then the chin, then the upper chest, and the upper abdomen, then lower abdomen, and then the arm area, then the thigh area, upper back, and lower back. So these are all the 9 areas, and the scoring is done on the basis of the presence of amount of the hair and the thickness of the hair, that is the terminal hair is present or not. And what are the criteria for diagnosis? There are various criteria and guidelines that has been followed across the world. So one of them is NIH criteria, that's in 1990, Rotterdam criteria, AE, Androgen Access Society, PCOS Society, then NIH 2012 extension, SSRE and SRM 2013, and that was modified in 2012. And all the criteria, they include the ovulation dysfunction with hyperandrogenism, and some criteria, they also include the presence of PCOM in the ultrasonograph. And in the latest criteria, the phenotypic identification also should be done. So basically, we should have hyperandrogenism and some evidence of ovulation dysfunction also should be there. But whenever it is required, we should also look for the PCOM pictures in the ultrasonograph. But certain situation we should also look for when there is sudden onset of hyperandrogenism. Suppose one girl came with sudden onset of hyperandrogenism. In that case, you should ask for a testosterone level. If it is slightly elevated, so definitely it's diagnosis of PCOS, but it is very high, like more than 200 nanogram per deciliter. You should suspect for adrenal or ovarian tumor. For that case, you should go for imaging. But when you go for DHEAS, if it is slightly elevated, again, it is PCOS, and if it is very high, that is more than 8 nanogram per ml, you should suspect the adrenal tumor, then you should go for imaging. And 24 hours urine cortisol or overnight DEXA suppression, urine-free cortisol, if it is more than 20 microgram per day, is also suggestive of Cushing's syndrome. In certain situations, you should also rule out presence of Cushing's syndrome. There are new guidelines, that is 2018 ESSRE and ASRM evidence, the best guidelines for PCOS assessment. So if at all you go for the ultrasound, it should be done transvaginally. This is the preferred method for diagnosis of PCOS, but whenever you go for that, look for how menarche, the time of the menarche. If the menarche is less than 8 years after the menarche, then ultrasound should not be conducted. That is because in this age, normally the girls, they have multifollicular ovaries. That is a physiological condition. If the patient is more than or equal to 8 years after menarche, in that case, you should go for the ultrasonograph. The follicle number per ovaries should be more than 20, or an ovarian volume of more than 10 ml should make the diagnosis. So Rotterdam criteria, they said in one or both ovaries, ovarian volume can be more than 10 ml. It is more than 20 follicle or measuring about 2 to 9 millimeter in diameter, echodenstroma, and typical black pearl necklace type of image can be seen in the sonograph. So in patients with irregular menstruation and hyperandrogenism, USG is not necessary for a diagnosis. However, USG can identify the type of genotype. So irregular menstrual cycle, normally in our OPD, what we follow, if it is less than 21 days and if it is more than 35 days, we call it as irregular menstrual cycle. However, it also depends on how many years they are post-menarche. In 1 to 3 years, it is different. You can take it as less than 21 or more than 45 days. If it is more than 3 years post-menarche, it is less than 21 and more than 35 days. If it is more than 1 year post-menarche, any cycle more than 90 days is irregular menstrual cycle, and primary amenorrhea means at age 15 or more than 3 years post-Larky. And free testosterone, they are more sensitive than the total testosterone for establishing the androgen excess and should be ideally determined through the equilibrium dialysis techniques. And serum EH, they don't have any role in the diagnosis. However, it is increased by 2 to 3-fold higher during the reproductive life in PCOS comparable to the healthy women. But it is normally is a marker of ovarian reserve, but definitely not a diagnostic marker for PCOS. And ACOG recommends all women suspected of PCOS should be screened for 70-hydroxyl progesterone to rule out late onset CAH. PCOS and CAH can be differentiated from each other only by lab testing, and overnight suppression test also considered in all cases. So how do you do the evaluation, the diagnostic evaluation, ACOG evaluation that says these are the following investigations which are required for the diagnosis? Obviously, you have to rule out pregnancy before going for further investigation. Also rule out certain medications in the form of androgenic steroids, dopamine antagonists, and go for TSH, prolactin, LH, FSH, testosterone. And if required, it is 17-hydroxyprogesterone to rule out NCCH and androgen. If you find the higher androgen, definitely hyperandrogenism. So obviously, you have to rule out certain situation that mimics PCOS like pregnancy, medications, thyroid disease, hyperprolactinemia, non-classic congenital adrenal hyperplasia, androgen secreting tumors, outflow tract obstruction that causes amenorrhea. So these are all the situations should be ruled out, and these are all the differential diagnosis. Then what are the biochemical markers of PCOS accepted everywhere? Elevated androgen, that is testosterone more than 60 or free testosterone more than 0.75, elevated LH-FS ratio, increased insulin level not needed all the time, insulin resistance is also not needed, but ultrasound appearance can help in your diagnosis. Long-term consequences we need to know. This is new actually about PCOS. So there are many comorbid associated with PCOS. One is obesity and metabolic syndrome, impaired glucose tolerance, type 2 diabetes mellitus, NAFLD, endometrial cancer in the long run, infertility, that is because of the aneuploitation, and obstructive sleep apnea syndrome, and cardiovascular disease, and most important is depression and anxiety. Normally, we don't take care about it. We don't ask about it to our patients. So what are the management goals? So management goals means definitely we have to first have a symptomatic diagnosis, then we have to have a symptomatic relief definitely. So the management aim is to restore the cycle first, regularize the cycle and treat the anovulation, restore fertility, treat anovulation, to treat the clinical symptoms in the form of obesity, insulin resistance, hirsutism and acne, and prevent endometrial hyperglycemia and endocrine cancer in the long run. So these are all the management goals. Then this is the flow chart for the management. How do you approach the patient for the management? The patient concern is definitely important. As we know, hirsutism is a very important symptom that is in PCOS, and infertility, again, obesity, menstrual irregularity. So you have to ask what is important for the patient. For what if the patient is concerned? Suppose patient is unmarried and hirsutism is a concern for her. So obviously we should first treat the hirsutism. And if the patient is married and wants infertility, in that case also the infertility should be a concern for the patient, and that should be targeted fast. At the same time, definitely if the MC irregularity is there, so that should be treated fast. So first look for the anovulation or the menstrual irregularities and the anovulation and infertility. So anovulation and menstrual irregularity, the first line of treatment is definitely hormonal contraceptive drug like estradiol. Second line could be metformin. And if the anovulation and infertility is there, the first line, as you know, it is clomiphene, and second line should be letrozole, and second line may be metformin, and sometimes third line treatment should be surgery. Then look for the clinical symptoms. If the patient is obese and weight loss is the primary treatment protocol, so to reduce the insulin resistance, exercise and diet control, so that also in the long run, and with the treatment, when you advance the treatment, that improves the insulin sensitivity and improves the ovulation. And stress management, of course, is very important while planning for the weight loss programs. Stress management reduces also BMI and reduces lipids and calorie intake. Diet control improves in the mood and depression also. The second is the insulin resistance. The first line is metformin. So of course, lifestyle modifications should be implemented. Hirsutism, if present with infertility, electrolysis and light-based therapies should be done with menstrual problems. First line is hormonal drugs. Second line is spironolactone, electrolysis, finasteride. Third line is metformin. If acne is there with infertility, topical creams should be used like benzoyl peroxide. With menstrual problems, first line treatment is hormonal drugs, topical antibiotic creams, and second line is the spironolactone. So this is the flow chart for a comprehensive treatment protocol. We'll just discuss individually. So what is the drug therapy for anovulation and menstrual irregularity? The first line medical therapy is an OCP to induce the regular menses, because this inhibits the ovarian androgen production and also increases the HSPG production. That way it reduces testosterone level. And ACOG recommends the use of combination of low-dose hormonal contraceptive agents for long-term management of menstrual dysfunction. Ethinyl estradiol combined with dospredan, that is as known as Asmin. Just a moment. Asmin has progestin effect that acts as an anti-androgen, and pregnancy should be excluded before using OCP. Everyone knows about it. And the second line therapy is metformin. So this is the treatment protocol for anovulation and menstrual irregularity. And the ACOG and SOGC guideline is clomiphene citrate should be used as the first line therapy for ovulation induction at least for 6 cycles, and those should be started at a dose of 50 milligram to start, and it can go up to 150 milligram per day. An alternative first line therapy to stimulate ovulation induction can be letrozole, that is aromatase inhibitor, and the second line therapy is metformin when clomiphene citrate fails, and is either exogenous gonadotropin or surgery. Third line therapy is laparoscopic ovarian surgery, that is called as LOD, and gonadotropin therapy is expensive and is also, it has its own drawback, like it increases the risk of multiple pregnancy and ovarian hyperstimulation syndrome. So this should be avoided. So the first or 2 line of therapy should be given. Metformin frequently improves the ovulation rates and pregnancy rates, and pre-treatment with metformin enhances the efficacy of clomiphene for inducing ovulation. You can consider the combination of metformin and clomiphene in older women with visceral obesity and clomiphene resistance. So this can be another mode of therapy also. So next comes the role of bariatric surgery. So what are the role of the surgery in PCOS? So as you know, bariatric surgery that causes significant weight loss. And one one article that I saw in JCM, the fertility and pregnancy outcomes in women with PCOS following bariatric surgery. So what they have seen, that pregnancy and fertility rates is, in very obese women with PCOS after bariatric surgery was very high, with few maternal and neonatal complications. So next comes the treatment of hirsutism. Hirsutism with infertility. So I have already discussed, you should go for electrolysis, laser, depilation, epilation, eflornithine use also. It can be used as an adjunctive therapy. And those patients hirsutism with menstrual irregularity, first line is the oral contraceptive, second line is spironolactone, finasteride, and flutamide, electrolysis, and cyproton acetate also can be used. And third line therapy is metformin. You can use it in the dose of 500 milligram TDS, and dose of spironolactone is 50 to 100 milligram BD combined with OCP to avoid the intramenstrual bleed. So you have to take care of the intramenstrual bleed also. GnRH agonist in resistant cases can be used. Weight reduction by 5 to 10% does wonder with the patient. Even it can reduce the hirsutism. Next comes the treatment of acne with infertility. As I already discussed, we can use topical benzoyl peroxide with menstrual irregularity. First line again OCP, topical antibiotics, tretinoin. Second line is spironolactone, and lifestyle modification is also required. Next is the treatment of obesity and insulin resistance. Weight loss is very important. Stress management, exercise, diet control, metformin, morbid obesity, if there, then bariatric surgery should be done. So 5 to 10% weight loss improves the hirsutism, menstrual irregularity, and even fertility also. So what is the management adolescent and young girls? So in adolescent and young girls, metformin can be given in a dose of 500 milligram twice daily is the first line monotherapy, or it can be used in combination with OCPs and antiandrogen medications. In case of lean PCOS, those were lean girls, low dose of metformin in a dose of 850 milligram daily may be effective at reducing the PCOS symptoms. But when the patient is overweight and obese, adolescents, dose escalation can be done to 1.5 to 2.5 gram daily is likely to be required. And need to be very careful in giving the anti-androgen therapy to adolescent girls. That is because it could affect the bone mass, although many short-term data they suggest there is no effect on the bone loss. So next we'll discuss about a very interesting thing, that is metformin in PCOS. As you know, metformin acts at each stage of PCOS by just improving the insulin resistance, because PCOS, the most important defect is the presence of insulin resistance. It acts at each stage in women of PCOS by improving the insulin resistance. It works in menstrual irregularities, anovulatory PCOS, PCOS who are undergoing IVF and during pregnancy in PCOS, metabolic dysfunction in PCOS, those who are having type 2 diabetes mellitus. So all these cases, metformin improves the ovulation, increases the pregnancy rate, prevents ovarian hyperstimulation, increases the live birth rate, significantly reduces the miscarriage rates, reduces the risk of GTM, also improves dysglycemia and other metabolic dysfunction. Of course, it improves the menstrual irregularities and the hirsutism. Next, we'll discuss what are the new treatment options. So exploring the new treatment options. So it has been revealed that the PCOS patient, they have a lower levels of incretin hormones that has been documented in a recent study. So targeting this system probably can be used as an alternative therapy. It helps in weight loss as in case of type 2 diabetes mellitus, and exploring other treatment like review of a novel anti-diabetic agent, that is SGLT2 inhibitor. It was done in a few patients, like 39 women patients. So SGLT2 inhibitor in the form of empagliflozin was used, and it was compared with metformin. And what was found that in EMPA-treated patient, they had a beneficial effect on weight, BMI, waist circumference, hip circumference, and total body fat in overweight and obese patient as compared to the metformin. But there is no difference in were seen in hormones and metabolic parameters, including the insulin resistance and the androgen levels. But it definitely in the long run, in future, probably this will have a better effect, and we'll see many other papers also. Next, the effect of GLP-1 receptor analog in the cardiometabolic complications in a rat model of postmenopausal PCOS. So in the study, it was shown that Lira showed a promising pharmacotherapeutic profile, ameliorating the most cardiometabolic complications. Next comes the surgical intervention. Some surgical interventions can relieve PCOS, like the bariatric surgery. Bariatric surgery in case of morbid obesity, it can be an effective treatment for obesity when other treatment options they fail. The risk, however, is there, including the surgery and dietary complication, as you know, and the pregnancy should not be pursued during at least the 12 months following the surgery. There is another surgical intervention that is called as LOD, laparoscopic ovarian drilling. This is basically a procedure that is used, laser beam is used, or with a surgical needle, just aiming to reduce the androgen level. So drilling is done inside the ovary, and that can reduce the androgen level. And the result is really great, and it reduces multiple pregnancy and ovarian hyperstimulation also. But unfortunately, it reduces the live birth rates. This is also an option in cases of clomiphene citrate resistant ovaries, and when letrozole is not an option due to off-label use. And this laparoscopic ovarian drilling carries risk associated with surgery, such as infection, adhesions, and cyst aspiration also is another procedure. You can remove the fluid from the cyst. That also can help in alleviating the symptoms of PCOS. So there are certain situations like, does PCOS put women at risk for other health problems? As I said in the first slide, all PCOS women need periodic screening. That is because 50% of the women will have diabetes or pre-diabetes before the age of 40. Risk of heart attack is about 4 to 7 times higher than women of the same age without PCOS. They have higher risk of hypertension and hyperlipidemia. They can also develop sleep apnea, and they develop anxiety and depression. They are also at risk for developing endometrial cancer. So definitely all the PCOS women, they need periodic screening, but it is not known in how many years gap or when. So it is not known, maybe in future we'll come to know. So this is the conclusion slide that is based on the AS and PCOS Society 2015. The PCOS is a multigenic heterogeneous complex disorder, most common endocrine disorder among reproductive women. The diagnostic criteria should include two of the following three criteria, that is the chronic anovulation, hyperandrogenism, and polycystic ovarian syndrome. And women with PCOS, they should also be evaluated, treated for reproductive function, hirsutism, alopecia, and the acne. In addition to the clinical findings, you can obtain the levels of 17-hydroxyprogesterone that can help in excluding the presence of late onset CAH and also rule out Cushing syndrome. Free testosterone are more sensitive for determining the androgen excess than the total testosterone level and should be obtained with equilibrium dialysis techniques. Adolescent girls with PCOS, they remain a diagnostic and therapeutic challenge. Treatment includes, depending on the symptoms, and they include OCP, spironolactone, metformin, letrozole, GnRH, GLP-1 rash, and in case of hypertrichosis type of PCOS, other available treatments are finasteride and the finasteride and flutamide. Women taking spironolactone require reliable contraception, and oral contraceptive is preferable, but if that form of contraception is not contraindicated. Ovulation induction in the form of clomiphene citrate or combination of metformin and letrozole or maybe GnRH analog can be used. AIM is not adequate for a diagnosis, should not be used, and all patients need periodic screening for diabetes, hypertension, CVD, DLP, and later on maybe endometrial CA. Education, self-empowerment, multidisciplinary care, and lifestyle intervention are very, very important tools for preventing the consequences of PCOS. Thank you very much for your patient hearing.
Thank you, ma'am, for such a wonderful talk. So, one question from my side. For this hirsutism, do you have any preference of OCPs?
See, low dose ethinyl estradiol is, I think, is the best. With small dose medroxyprogesterone, as these days we are also using drospirenol. Ethinyl estradiol with drospirenol.
Yeah, because the guideline don't favor any or are not against any. So your personal experience, like for most of patients, what would you prefer?
I use this ethinyl estradiol normally, low dose with non-ethestrone, the progesterone. Not drospirenol I don't use. Normally I start with OCP plus metformin, and if it is severe, I definitely add finasteride. 5 milligram once daily, and that makes wonder. Within 3 months, patient improves.
And for those patients who have improvement in hirsutism after, let's say, a therapy of 6 months or 1 year, but later on relapse, so do you reintroduce, and for how long?
That again 1 to 2 years. I always explain the patient that treatment is a long-term treatment. It will take 2 to 3 years. But in the meantime, I definitely suggest all the girls to get married as soon as possible and complete their family. So that is one part of the counseling you should make to all patients.
Thank you. I don't see any question. Any more question? Yeah, Dr. Kanaiya.
Like this is also we have been taught getting marriage definitely reducing the hirsutism and improve the menstrual regularity. So like how does it usually affect the things like hirsutism and irregularity?
See, pregnancy itself doesn't reduce the hirsutism, because before marriage, actually, we treat the patient. Most of the androgens, they normally go away. So during that time, patient conceive and the pregnancy goes through and the patient delivers the baby. So after that, I don't know by which mechanism the cycle also becomes regular. Because by that time, we counsel a lot, patient follows the diet and all. And actually, the primary goal of counseling the patient to get married is to prevent infertility, because as the patient ages, the chances of infertility is much higher. So that is the reason we ask them for an early marriage, so that at least the patient should complete the family. Otherwise, hirsutism and all, anytime we can treat, but infertility will be very difficult to treat as the patient ages. So that is the reason. So we are not much concerned as an endocrinologist. We are not much concerned about hirsutism. We can treat it by any means, by mechanical or by hormonal, whatever. Okay. So yeah, tell me.
Like after delivery, they gain the weight. So again, we think that gaining the weight increases resistance.
We'll restart the treatment.
Okay. Thank you, ma'am.
Yeah, and one more question, like all the gynaes do prefer myo-inositol.
See, that is basically is a dietary supplement, and what I've seen through the literature, it just aids in the insulin signaling. But how does it help? I don't know. I never use it. But most of the gynecologists, not only they add this drug with that, metformin also, they continue it throughout the pregnancy. I was going through one article. So they have clearly mentioned metformin, if at all you are using in PCOS and patient got pregnant, maximum you can use until 3 months. After that, you should stop it. Otherwise, it can cause prematurity of the child, growth retardation, sometimes large babies. There are many complications of use of metformin during pregnancy. But these that I can see many gynecologists without thinking anything, they are just giving metformin 500 milligram 3 times daily. I think that should be restrained.
Yeah, I totally agree. We have one question, though you have covered in your talk. So sonographically, how many and how much size cysts should be in ovaries? That's a question from a delegate, but you have covered just
yes, recent guideline, they say 20 follicles, and the volume should be 10 ml, more than 10 ml. Yeah. It's the recent guideline. But the earlier Rotterdam criteria, they were saying it is 12 follicles per ovary.
So just to add to that, to best of my knowledge, it is basically dependent on what frequency of USG you are using.
Yeah, so that's also how much hertz it have, 8.
Yes, and the previous guideline used 5 hertz. That is why the difference is there. So it depends on the how high frequency you are using. The more the frequency would be, more clarity in the picture.
Clarity will be there.
Changes.
Yeah, but that should be also transvaginal, because most of the patients, they are obese. So the false result also you can get, because fat also, that you cannot detect the follicles clearly. Clarity will not be there.
So I think with that, all the questions have been answered. Thank you. Thank you very much.
Thank you. Thank you, Mayur. It's a great program. So every year we'll conduct.
Yes, sure.
Congratulations to youngsters doing really good things.
Thank you. Thank you, ma'am. Thank you for the appreciation. This keeps us moving.
Congratulations. Chalo. Okay, thank you. Thank you so much. Okay, chalo. Bye-bye. Good night.
Good night, ma'am. So next speaker could not make it. Dr. Tejal had some medical emergency. So we'll just move on to another session. So we have now exchange of views. First would be metformin in GDM, whether to give or not. It's a good talk to discuss. For that, we have Dr. Anshul Agrawal in favor of no, and Dr. Saqib Ahmed Khan in favor of yes. So let's hear from Dr. Saqib. First, he'll be talking in favor of metformin in GDM. So tech team, please show the CV. Yeah, Dr. Saqib is DM Endo from Merit and MD Medicine from Kanpur. He has also done MRCP SC. He is an avid speaker in various national and international conferences, various publications. Currently working in Lucknow with Chandan Hospital. Over to you, Dr. Saqib.
So thank you, Dr. Mayur Agrawal, and thank you, Hormone India, for this wonderful opportunity and wonderful organization. So we'll be discussing about a problem which is a very prevalent one, and it is still a debatable topic, that we should use metformin in pregnancy or not. So I would be just sharing the evidences, the views of mine in favor of metformin in pregnancy. So metformin, to give or not to give. So first, before discussing about that it should be added in the armamentarium of the treatment of GDM or not, we'll be discussing about what the problem is. And because actually the time we spend on choosing the option on one hand, which is the metformin, and on another hand, which is the insulin, which is the most potent option against any degree of hyperglycemia, but we know that there are a lot of inhibition, there are a lot of challenges when we are introducing it. So the occurrence of GDM, we know that it parallels the prevalence of impaired glucose tolerance, obesity, and type 2 diabetes. We know that diabesity is a pandemic, and likewise on a parallel horizon, the incidence and prevalence, the incidence of GDM is also increasing. So with the age of onset of diabetes, which is much earlier, and pre-diabetes, which is much earlier, and the age of childbearing, which is actually rising in almost all the countries, we expect to have more and more prevalence of those who are having GDM in their pregnancy. When we talk about the data, so IDF estimates that 1 in 6 live births are to women with some degree of hyperglycemia in pregnancy. Out of those, 1/6 of them, they may be due to diabetes in pregnancy, which is pre-existing, and while the majority is related to GDM. 8 low and middle resource countries, which includes India, China, Nigeria, Pakistan, Indonesia, Bangladesh, Brazil, and Mexico, they account for 55% of the global live births, as well as 55% of the global burden of diabetes. So any recommendation should keep all those things into mind when we are opting for the pharmacotherapy in terms of an oral option or an injectable, which would be requiring more resources. So what are the pillars of GDM treatment? We all know that medical nutrition therapy, we cannot wait for long. 1 to 2 weeks of medical nutrition therapy, we can apply and wait if the degree of hyperglycemia is not much. On top of that, the diet, the MNT and physical activity, we would be requiring OHAs or insulin, and we know that we are having a very less number of OHA which we can rely on. So when we talk about the guidelines, what they say. So when we talk about the American Diabetic Association, so they say that insulin is the first line of treatment, but we have several randomized controlled trials which have supported the limited efficacy of metformin and glibenclamide in reducing glucose levels in the treatment of GDM. And these drugs are not recommended as first line agent for GDM because they're known to cross the placenta and lack data to demonstrate offspring safety. But they also say that metformin, when used to treat PCOS and induce ovulation, should be discontinued by the end of first trimester. It means during the organogenesis still it would be there. So ACOG, they say that for women who refuse to use insulin, or obstetrician or obstetric nurses who think that women who cannot safely use insulin, no doubt insulin is the most potent option, but where we cannot apply that, where the patient would be having the resistance against the usage of this, or they are having lesser resources against it. So metformin can be a reasonable second line choice, but it is necessary to inform patient the risk of adverse event, which we'll be discussing, like increasing prematurity, because it can actually cross the placenta, and lack of long-term data. When we talk about the FIGO in 2015, they say that insulin, glibenclamide, and metformin, they are safe and effective treatment option during the 2nd and 3rd trimester of pregnancy if blood glucose cannot be controlled by lifestyle changes alone. NICE guideline in the UK also say that metformin is used if the blood sugar target is not achieved through lifestyle changes within 1 to 2 weeks. If the patient is intolerant or cannot accept metformin, insulin is used. So they are not against the metformin. IDF also says that if blood glucose targets are not within the control in 1 to 2 weeks of MNT, insulin is treatment of child choice, but there is now sufficient evidence to consider metformin and glibenclamide in women who are known to be at risk. Combination therapy has not been studied specifically. Likewise, the Australian authority, they also say that insulin is the first option, but we can use metformin when the patient is opposed to injection. So we'll be talking one by one. So when we compare the metformin against the glibenclamide, so in the short term, in women with GDM requiring drug treatment, glibenclamide seems inferior to both insulin and metformin, while metformin with or without insulin performs especially with insulin when required, performs slightly better than insulin alone, and it is said by FIGO 2015. So when metformin can be used, so we know that in PCOS we are using it, and it actually helps in more number of pregnancies which can be attained in those where they are having ovulatory dysfunction, GDM, and pre-existing type 2 diabetes where they are already on metformin and they have conceived. So what can be the sequence of metformin use? Metformin alone, metformin followed by addition of insulin, or insulin followed by addition of metformin. So when we compare the metformin and glibenclamide, so metformin in head-to-head comparison was associated with less maternal weight gain, which was significant, lower birth weight, less macrosomia, fewer large for gestational age newborns, and average treatment failure was comparable to glibenclamide. Metformin was associated with lesser euglycemia. So actually it was having higher fasting blood glucose as compared to glibenclamide. It's shown to cross the placenta up to 50% of the concentration as compared to maternal concentration would be there when we will be testing the fetal circulation. However, it has been shown that the rate of adverse outcome, that is congenital malformation and neonatal hypoglycemia, they have found to be comparable to general population. So it's though they do cross the placenta, but the congenital malformation and neonatal hypoglycemia have not found to be higher as compared to the glibenclamide or even insulin, which will be seen. Another prospective study of 126 infants of mothers treated with metformin for PCOS during pregnancy has reported no adverse effects on the infant's weight, length, motor activity, or behavior at the age of 18 months. It is the more recent and more talk about trial, that is MIG trial, metformin in gestational diabetes, the largest randomized control trial comparing metformin with insulin, where Rowan et al. They randomized 751 women with GDM at 20 to 33 weeks to treatment with either metformin or insulin. So mind you, still it is either metformin or insulin, nor the metformin versus placebo or metformin against no treatment. So metformin was associated with a significantly lower rate of neonatal hypoglycemia. It was very significant, but with a higher rate of preterm birth. In the MIG trial, the rate of composite neonatal morbidity, which was including the neonatal hypoglycemia, respiratory distress, need for phototherapy, birth trauma, 5-minute Apgar score of less than 7, or prematurity, it was comparable in the metformin as well as insulin group. In addition, there was no difference in the degree of glycemic control and in umbilical cord insulin level between the metformin and insulin group, which was very significant. And metformin was associated with a lower birth weight gain during pregnancy. And we know that macrosomia is a more commoner concern of us as compared to prematurity or small for gestational age in GDM, though they both may be a problem in our GDM patient. So furthermore, the majority of women in the metformin group stated that they would choose to receive their assigned treatment again. So mind you, even if we have insulin as a most robust option, we know that there are a lot of barrier, and metformin's accessibility is much higher. And this MIG trial also attests to this, and nevertheless, metformin was associated with a failure rate of 46.3%. So 46% were still requiring additional insulin on top of metformin. So when we compare the primary composite outcome, so recurrent blood glucose level of less than 55, that is neonatal hypoglycemia, was much less in metformin group as compared to insulin group, and it was statistically significant. The other difference which was there was in terms of spontaneous
I think there might be some little glitch.
We can just hold for a minute, doctor.
Yeah. I will just call him.
Yeah, reconnecting. Good evening, Dr. Anshul. How are you? You're muted.
I just have a talk with Dr. Shakib.
No, he's back.
He's back. Yeah, he's back.
Good evening, Dr. Mayur.
Hello.
Just all the delegates bear with us. Dr. Saqib got disconnected. He's trying to log in.
Technical glitch.
Yeah.
Hi again, and sorry for the technical glitch. So I would be starting again from the point where I have left.
Dr. Saqib, if your internet is unstable, just switch off the video so that you can present. Yes, that's better.
Okay. So probably I'm audible again.
Yes, you're well audible.
Okay. So we were talking about the MIG trial, which we are showing the primary composite outcome, that one pros of metformin against the insulin was that the neonatal hypoglycemia was less in metformin arm, clearly statistically significant as compared to insulin group. The spontaneous preterm birth, that is early birth, was much higher in metformin as compared to insulin group, and it was statistically significant. Apart from that, the other neonatal glucose tolerance and acceptability of treatment. So they were also comparable. They were actually requiring addition of insulin on top of metformin. So more women stated that they would choose to receive metformin again, and the acceptability was very good. The rates of other secondary outcomes did not differ significantly between the groups. There was no serious adverse events associated with the use of metformin. Supplemental insulin was required in 46%, and glucose levels were the indicator that those would be having more chances of requiring insulin on top of metformin. Preterm births were more in metformin, as I've said. Spontaneous preterm birth, we can expect more in metformin. So these were the baseline characteristics. Who were requiring supplemental insulin, those who were having higher BMI at enrollment, they were having more odd of requiring insulin. So when we talk about the perinatal outcome in GDM, so there is lesser macrosomia in birth weight, lesser cesarean section, lesser neonatal hypoglycemia and ICU admission, lesser maternal hypoglycemia, lesser maternal weight gain during pregnancy, and hypertension. The con is that we can expect more small for gestational age and preterm delivery. Those patients who were prospectively followed in the MIG trial and in some other trial, they have shown some red signs also, like we have seen in this systematic review and meta-analysis that following intrauterine exposure to metformin for GDM, neonates are significantly smaller than insulin-treated group. And not only that, they have accelerated postnatal growth, resulting in heavier infants and higher BMI by mid-childhood. Such patterns of low birth weight and postnatal catch-up associated with adverse long-term cardiometabolic outcomes. And this is a red flag which should be further corroborated with other larger studies, that if it is true for a larger population to that has been exposed to metformin or not. So just to summarize, that metformin is safe, or in some respect even better in terms of immediate maternal and fetal outcome. Possibility of childhood obesity, especially in those who were small for gestational age, and shows catch-up growth. Insulin can be offered as first-line therapy after trial of MNT, but consequences of maternal hyperglycemia, if they are denying any treatment, is worse than possible risk of metformin. So we should use our option judiciously. We should discuss and document the risk-benefit aspect of metformin, and then we can definitely prescribe this option to our patients. With this, I would just end my deliberation. And in all those where we are not having such concern, like where the growth is already documented to be retarded, where there is more concern for preterm delivery, we can use metformin and we can benefit a lot of patients, especially when the patient refuse for insulin, which can be a case for a lot of patients when they come from the periphery, and because we are catering up an area where we are having more resource poor population, so it is always an option for us.
Yes. Thank you, Dr. Shakib Ahmed. It was a very nice lecture by you. You had pointed out why, and you had even given us the options where we can give metformin. But I have one quick question for you, which is more of a practical thing. Like, we have many patients being referred to us from gynecologists with the diagnosis of gestational diabetes, and they had already put the patient on metformin with good glycemic control. So what would you do in that scenario? Do you continue that metformin, or do you take off metformin? Because many of the time what we find is that when we take off metformin, then the insulin dose requirement is may not be very less. It tends to be slightly high. So what is your saying in that scenario? Will you take off metformin, or do you continue the metformin?
I think Dr. Saqib connection is poor. We'll just take up the Dr. Anshul's talk. Also, it's an exchange of views, so we can take the question at the end.
Okay, sure.
So, CV slide, tech team for Dr. Anshul. Over to you, Dr. Harsha.
Yes. Good evening, everyone. Now for the second part of this topic, that whether we should give metformin or not in gestational diabetes, we had a talk by Dr. Shakib Ahmed Khan pointing out why we should give metformin. And now we have Dr. Anshul Agarwal present the other side of his debate. So we welcome Dr. Anshul Agarwal. He is an MD DM endocrinology He's a consultant endocrinologist in Vinayak Hospital, Jhansi. He's a member of European Society of Endocrinology, ADA. His first rank in MD medicine, and he has published several publications in journals. Areas of research are diabetes, thyroid, and so Dr. Anshul, please go ahead.
Yeah, thank you so much for that nice introduction. And first of all, I would like to congratulate Team Hormone India to have organized such a great meet in such a large scale. So topic which has been assigned to me is about the role of metformin in gestational diabetes. I would be talking mainly that there is no role in gestational diabetes. Dr. Saqib has very well explained that metformin has been used for GDM nowadays. And after the advent of MIG trial, it has been advocated by multiple guidelines that metformin should be considered in gestational diabetes, providing the benefits which the metformin is providing in terms of reducing the neonatal hypoglycemias, in terms of reducing the insulin dose. So, but what are the other problems which we are facing, which we could face after we start with the metformin? So before starting metformin, first of all, we should be answering these questions first. That what metformin dosage is being found to be safe in pregnancy? Do we have any answer to that? Because none of the studies have shown that 500, 1000 or 2 gram, what dose is actually sufficient and which should be considered to be safe to be used in pregnancy. Next question which comes to our mind is that metformin, insulin on the one hand don't cross placenta. On the other hand, metformin crosses the placenta. So if the drug is crossing the placenta, and in fact, there are multiple studies which have shown that metformin will achieve either the half the concentration in the fetus as compared to maternal circulation. Some have shown it will be almost the same concentration, or some have shown even the higher concentration. So if metformin reaches at least the same concentration in the fetus as compared to maternal circulation, it might have some impact on the fetus, not on the short term, but it could have been in the long term also. So these questions should always be kept on our mind before we are starting metformin in a pregnant lady, because this is a state where we should be cautious not only for the mother, but also for the fetus. So metformin, what it does is, through the organic cation transporter present in the placenta, metformin crosses the placenta, reaches the fetus. It has multiple pathways by which it will increase the AMP kinase activity, which inhibits the gluconeogenesis. Hence, the nutrient uptake in the fetus will be lowered. mTOR pathway will become inactivated, which actually is responsible for cell growth and proliferation. This is the phase where fetus requires maximum growth and proliferation. These things again can get restricted. Supratherapeutic dose of metformin again can inhibit the complex 1 of mitochondria, reducing the ATP production. Again, this might be harmful to the fetus in the long run. So these are some actions of metformin which are dreadful and can have impact on the fetus. So overall, if we see that if metformin causes AMP kinase activity, it has shown in studies that it might involve in the replicating and differentiating cells in the fetus. It might have a restrictive consequence. Then even in the mice study, it has shown that there are some anti-growth or restrictive effects, not only on the normal cells, but also on the fetal pancreatic beta cells. This has again been shown with the metformin. Again, the next action of antifolate mechanism of metformin can lead to methionine deprivation in the fetus, ultimately can lead to decrease in the protein synthesis. So all these actions could be there with the metformin. Overall, this is just a summarization that if metformin crosses the placenta, it impairs mitochondrial respiration, inhibits the nutrient uptake, decrease in the gene methylation. Ultimately, what it does, it will restrict the fetal growth. So you will find that just the babies will be born small, as not appropriate for the gestational age. And these babies will have been found to have an increased risk of future cardiometabolic disease. So again, pointing to the question, is metformin safe in pregnancy? So why we are talking about the role of metformin is after this landmark trial, MIG trial, which was done in the patient with GDM who were given either metformin plus minus insulin versus insulin alone. This study have shown that the pregnancy outcome in both the arms, either metformin plus insulin versus or the insulin alone, both had shown good pregnancy outcomes. So there was no increase adverse outcomes in any of the arms. And hence, now we are talking that metformin has been found to be very safe in pregnancy. However, one thing which was against metformin in this trial again was increased risk of preterm birth. This was found. Overall, outcomes were found to be similar. But if I would just highlight the study again in the future studies, the same cohort, MIG trial, was followed up in a MIG tofu trial. So the offsprings who were born to those mothers who were exposed to the metformin, they were followed up after 2 years. And what it was found was that body fat has showed no difference in both the arms. However, those offsprings who were exposed to metformin during the gestational period, they were found to have a higher mid-upper arm circumference was larger. Similarly, biceps and subscapular skin fold thickness was found to be greater, suggesting, is there a different pattern of fat deposition because of the metformin which was exposed in those offspring? And if this difference in the fat deposition persists, will it be associated with difference in the insulin sensitivity later on in their life? Will it cause more insulin resistance, predisposing the offspring to the cardiometabolic part later on in the life? These are the questions which are highlighted by this study. Again, MIG trial, same offsprings were followed by around 7 years in one cohort and 9 years in another cohort. This was a MIG tofu trial. The 9-year-old offspring in the Auckland cohort, what it was found was that the offsprings who were exposed to metformin in utero, they were found to be larger in terms of body weight by waist circumference, in terms of higher arm circumference and higher BMI. Abdominal fat and total abdominal fat seen with MRI was found to be similar, but there was some trend towards increment in the abdominal fat percentage among the offspring who were exposed to metformin. Overall, if you see this follow-up trial of MIG, overall, the safety of metformin has been exposed in the long run. So, safety in the offspring is now unclear. Again, a similar studies like MIG tofu trial. This was a systematic review of almost 28 studies comprising of almost 4,000 participants have concluded that neonates who were born to mother who were exposed to metformin were found to be significantly smaller. Then they will grow faster. They will have an accelerated postnatal growth, resulting in a heavier infant. And overall, by reaching mid-childhood, they will be having a higher BMI. This was a statement from this review. So you can see that later on, immediate results are not much, but in the later on in the life, you will find that they are more predisposed to the metabolic part profile might be disturbed in the patient with offspring of those mothers who were exposed to metformin. Next, some have raised the concerns about even the fertility of the male offspring in the adulthood. By what was the mechanism? There was an increase in the spermatozoa head abnormality with greater DNA damage because of the lower expression of the TET1 protein. So even the male fertility might be hampered, and this is one concern. Now, metformin not in GDM, but also has been used in PCOS for treatment or just for a ovulation induction. So metformin once used for a ovulation induction in a PCOS might be continued in a whole pregnancy. So there are many studies in terms of PCOS context also. Lately, Norwegian children who were born to women with PCOS, they were studied. It was found that their infants were heavier. Same researchers, they have observed that after 4 years of age, either male or female children, both were found to have a higher weight with an odd ratio of almost 2.17, suggesting that twice the risk of having higher weight to those mothers of PCOS who were exposed to metformin. Again, another studies whose PCOS patients were treated only with a small dose of 850 milligram of metformin from first trimester to term. They have shown that after 8 years of age, those children who were exposed to metformin in utero, they have strong they exhibit strong preponderance towards having a higher glucose level, strong trend towards having an increased blood pressure, and a higher LDL cholesterol level, suggesting higher risk of metabolic syndrome in those offspring who were exposed to metformin. Considering these facts, should we be considering, after the long-term effect has been shown in some studies to be dreadful, should we be considering using metformin? Now, not talking about the studies, if we go with the ADA guidelines also, this is the latest ADA 2023 guideline. What they suggest is insulin is the preferred medication for treating hyperglycemia. Metformin should not be used as a first-line agent. Why? Because it crosses placenta to the fetus. So this is the statement from ADA. Similarly, even if in the patient, metformin was used in the PCOS patient, even for ovulation induction, should actually be discontinued by the end of first trimester. So this again has been highlighted by the ADA. So guidelines also are recommending that metformin should not be used as a first line when we have an agent like insulin, which has shown to be very safe. Insulin has shown to be very efficacious in terms of reduction of blood glucose. Overall, there is no difference in the neonatal birth weight, and offspring data again has been found to be very satisfactory with the insulin. So if we have a molecule like insulin, which is already available, then why to consider those agents which are crossing placenta and might have impact on the later on in the offspring. So if I would just have to summarize my talk, metformin passes through placenta. Concentration of metformin has been found to be almost same in the fetus as compared to maternal circulation. Metformin, though, thus can have adverse impact on the fetus growth. Long-term outcome data have shown that in utero exposure to metformin actually can lead to short for gestational age baby and have higher risk of metabolic syndrome in the future. MIG trial was a trial where metformin use was advocated because there were good pregnancy outcome. Only difference was there was a higher preterm babies in those patients who were exposed to metformin, those pregnant women who were exposed to metformin. However, when the same cohort was followed after 2 years, 2-year children were found to have more skin fold thickness, much higher mid-upper arm circumference, suggesting a difference in the fat deposition to those offsprings who were exposed to metformin in utero. MIG-TOFU 9-year cohort has shown that children were found to be larger. Even the children born to PCOS mother exposed to metformin, they have shown that there might be a high risk of metabolic syndrome by 8 years of age. So by mid-childhood, those patients might have an increased risk of metabolic syndrome. And final statement by ADA, insulin as the first line agent in the treatment of gestational, and metformin should not be considered as a first line. So with this, I would end my talk. Thank you very much, and waiting for the questions there.
Yes, thank you, Dr. Anshul Agarwal. You had presented very well why we don't prefer usually metformin as a mainstay of therapy. That we have evidence that compared to the placebo or with insulin, the chances of having a preterm or low birth weight or not having a high birth weight infant is more with metformin. Although that seems to be very good because patients with gestational diabetes tend to have large babies. But what is available from the data that you and Dr. Both Shakib has presented is that the neonates might be slightly low for birth weight. The number of C-sections might be less, but later on they gain more weight and hence they are predisposed to having metabolic syndrome. So until and unless we definitely have evidence, this is not only applies to gestational diabetes, I think even for the MIGHTY trial which studied metformin in type 2 diabetes pregnant women, it also shows even for type 2 diabetes, the exposure is from the start of pregnancy. So it is much more exposure, especially during the time of embryogenesis and all. Even that data also has the same picture. The number of C-sections having a normal birth weight is more likely with metformin, but later on they tend to gain more weight. So what question I was having to Dr. Shakib, I think this is more of a practical thing. So when somebody refers to you, a patient with gestational diabetes, many gynecologists, they are not comfortable with using insulin. they are under the pretext that it is absolutely safe. People don't go through all of these studies because we have knowledge about these things. Even if there is 1% a chance of a problem, we don't use that drug. But gynecologists and obstetricians, they usually write left and right metformin. So what do you do in your settings? Do you continue metformin in that setting, or do you stop metformin and then say that you explain all these things? Because I had tried many of my patients, they simply say sugars are controlled, we would like to take metformin. I think Dr. Shakib has also said in his study, in his data, that women prefer metformin over insulin. So probably, I think it's both of you are correct. What will you do, Dr. Shakib, Dr. Amkin?
So actually, our job is to let them know that what are the pros and cons of the options which they are having. Suppose I'm just giving an analogy, like when a patient comes to us with the grave disease, we explain them that what are the options. Everything has a problem. Like when we talk about the anti-thyroid drug, they have a problem. Radioactive iodine ablation, they can have a problem. Surgery is have their set of challenges and the problem. But we explain them what are the pros and cons and why you can choose one option over another. Likewise, we can give all the options and we can explain them. So even because actually those trials have not compared metformin against placebo, we know that when we go by the Barker hypothesis, when the patient is exposed to undernutrition or overnutrition, the patient would be having more risk of those postnatal catch-up growth. And we have seen this when the patients is delivered with a small for gestational age, they will be having such kind of picture, and they will be having more risk of PCOS when they are girl. So they just attest that those who are born to any GDM mother, they would be having more risk of metabolic syndrome and those things. So it is actually because of that risk, or they were predisposed to metformin, or because we are not comparing against those who were controlled with the help of placebo. Because it is said that even in that data, that 46% of them, they were not controlled with the help of metformin. So was it that thing? I accept that insulin is the most potent option, and I have cleared this thing. It would be the option which would be working in any case. So even in a type 2 diabetic base, if we give basal bolus in any decompensation, we can have a good outcome. We would be explaining that to patient, but we know that how difficult it is to a rural patient or even to a type 1 diabetic parent, that now you have to take it, but even after explanation for 1 hour, he will be consulting many a person and might go for further option. Our job is to explain them, but if the patient is comfortable with metformin, even after explanation of those things that it can cross to placenta, what pros and cons it can do, if we want to continue with that, yes, definitely I would allow the patient. If he want to switch after explanation, then I would switch to insulin.
Yes, I completely agree with you. Considering the Indian circumstances, Dr. Shakib, but some patients, they don't understand, no matter how much better we explain that these are the consequences, and that can backfire also. People think that we are explaining too much, we are frightening the patient. So it again depends upon the educational level of the patient. And the go-to insulin is always, again, in gestational diabetes, is a basal plus 3 times bolus insulin. So some patients even find it pricking 4 times a day quite difficult. So I completely agree with you that we can give metformin in some patients, but definitely I think we should put it on paper before prescribing that patient was explained so and that he denied insulin. So
yeah, I agree totally. It should be a shared decision between the doctor and the patient. Also, I believe it depends on the level of hyperglycemia, the duration of pregnancy, the trimester in which the patient is. That also changes the decision. So, Dr. Harsha, we have a question. I'll read it out. So Dr. Devmalya Sanyal has asked, after MIG study with higher late weight gain in long term should be using in late pregnancy?
So as I've said, the concern of ours is more about the large for gestational age, and the immediate data suggests that the immediate maternal as well as neonatal outcome are better. But when we talk about the long-term data, they raise a red flag sign. We need to explain it to our patient. We need to have more studies for with a larger patient pool. When we see this data, it is hardly having less than 1,000 total patients. So we can have more data. We have more. If we have more follow up in the future, then the picture might be more clearer. But actually, when we decide against the metformin versus none of the treatment, then definitely we can offer with the caveats explaining to our patient. When we are having very severe hyperglycemia where insulin would be required, then definitely we can have more emphasis on the option which would be required.
Yes. Thank you, Dr. Shakib, and thank you, Dr. Anshul. It was a very good debate sort of thing from both of you. Thank you very much. Yes, thank you.
Yeah. We have changed the heading from debate to exchange of views. We don't want anybody to fight with anyone.
That's why I said it's a debate sort of thing. Okay, right.
Really nice presentation from both of you. For the next presentation, we could not get Dr. Sharad Kumar. He has some personal issues, so only one part would be there. Dr. Siddharth Rake on HRT in postmenopausal women with no.
Yes. Hi. Good evening to all of you.
Text team, can we have the CV? Dr. Siddharth Rake. Yeah. Go on, Dr. Harsha.
Yes. Hello. Welcome, Dr. Siddharth Rake. So today, Dr. Siddharth Rake will be presenting about the HRT, and he will be presenting his views of why we should not give HRT. He's MD Medicine and DNB Endocrinology, and he currently practices in Indore. He has done his MD General Medicine from UCMS Delhi. 5 minutes. Kuch on, sir. 5 minutes. Sir, just 5 minutes, sir. He's a member of RSSDI, ESI, and API. And he has delivered various talks, and he has been a principal investigator in multiple clinical trials. So we welcome Dr. Siddharth to present his views of why we should not give HRT in postmenopausal.
All right. So first of all, thank you for the kind word of introduction, and a very good evening to the members of Brethren who are assembled here and listening. So just give me a second. I will start by sharing my slide. So the customary questions, my slides are visible?
No, it's still not visible.
I've uploaded these slides. Okay, so as I'm the last one, and as this is exchange of ideas, I had prepared a very short sort of presentation, and very informal kind of not much of a data type of a presentation. And I take it now the slide are visible.
It's still not visible. I think you should unshare and then again share your screen.
Okay.
Tech team, can you help with that? Dr. Rake is unable to share his slides.
Actually, it's not allowing me to share my slides. Wait. Okay, so my slides are visible now.
No, still it's not visible.
That's all right. Then we can go ahead.
Dr. Harsha, is it me who cannot see the slide?
No, even I am not unable to see, but that's okay.
Yeah, otherwise also there is not much written in the slides. It's just the context or the basic pro forma on which I will be discussing today's this thing. So we'll just begin. So what was the initial hope with which there was so much euphoria about menopausal hormonal treatment? So all right. So the initial hope when postmenopausal hormonal therapy was started, one was reducing cardiovascular mortality. There was ample amount of epidemiological data suggesting कि भाई इधर menses बंद होते उधर cardiovascular mortality बढ़ती है. At that time, whether it was association or whether it was causation was not fully verified, but nevertheless there was a lot of data of cardiovascular mortality with menopause. Second was osteoporosis. Again, ample amount of data that osteoporosis incidence of fracture, both hip, vertebral, and all the malarkey of osteoporosis increases after menses. And then there was obvious menopausal symptoms. And with these three topics in mind and one fear in mind, at that time also there was data that longer cumulative estrogen exposure leads to increased risk of malignancy, breast and endometrial. So with these hopes and fear in mind, postmenopausal hormonal therapy was started I think in late 90s, and it reached in peak just before the publication of famous WHI trial in 2002. So when 2002, this trial was published and this trial was stopped because of increased mortality associated with the treatment arm, there was a lot of hue and cry, lot of media publications suggesting कि भाई आपने तो दवाई दी उससे तो malignancy बढ़ रही है, and in fact postmenopausal therapy should not be done and should not be advocated to any patient. And subsequently over the decade or two, the prevalence of women on postmenopausal hormonal therapy has dropped from, I think, one of the article mentions that there was a time when in cities 65-70% of the patients were being offered postmenopausal hormonal therapy to current maybe 5 to 10% of the postmenopausal hormonal therapy. Now, one by one, we will see what the data suggest, what the data is there for different 3 points. The first one is cardiovascular outcome. So first, WHI data, and after that, most recently, USPSTF data. These data has ample evidence to suggest कि भाई cardiovascular mortality कम नहीं होने वाली है. In fact, there was increased thromboembolic complication, increased pulmonary embolism, increased cardiac. In one subset of the trial, there was decreased stroke. But if you see the later publication from the same group from 2002, subsequently over the decade, you will notice that whatever benefit as far as CV outcome was concerned disappeared over the time. And the ultimate conclusion was that if you are starting postmenopausal hormonal therapy with the intent of CV reduction, CV risk reduction, you are not going to get it. Second point is changes in the CV risk profile in the last 2 or 3 decades. It has been almost 21-22 years since WHI trial was published in JMA. And in these 21 years, cardiovascular risk profile has changed a lot. We have seen a paradigm shift as far as obesity, prevalence of obesity, prevalence of diabetes, and prevalence of other metabolic risk factors are concerned. If you calculate the average BMI of a population in 1980s or 1990s vis-a-vis in current decade or in current year, you will find that p-value is significant. And in some cities, we are seeing the prevalence of diabetes reaching 40%. So even though we say कि भाई in older trials, when the age was young, or in the age was less than 50 years of age, the CV mortality was not there. But that was a different era. This is a different era. Next is Indian phenotype. If we talk about postmenopausal hormonal therapy in Indian context, we Indians are predisposed to develop the metabolic complication at a relatively low BMI. वो उतने BMI में फिरंगी को MI diabetes नहीं होता है, and we are prone to develop all the metabolic complication, NFLD, diabetes, and everything at a relatively low BMI. So again, this point goes. Then the last point is availability of better agent for CV protection. If you think about that, we want to give hormonal replacement therapy for a CV protection, and as of now, we have far better agents available for the CV protection for risk reduction of the cardiovascular mortality. If you combine the change in the CV risk profile, the unfortunate Indian genotype-phenotype combination, and availability of better agent, as far as this point goes, cardiovascular outcome, I don't see that postmenopausal hormonal therapy can have better CV outcome in Indian context in the current decade. Second is malignancy. The trial was stopped because of increased risk of malignancy. Initially, they said that E+P had a higher risk of breast malignancy. Later on, the data emerged that it is the ultimate estrogen exposure which leads to increased risk of CA breast. If we talk about the risk factor of carcinoma breast, we say the age of menarche, the age of first childbirth, and these are the factors. And obviously, BMI, your peripheral aromatase and peripheral estrogen, all of these factors are the risk factor of carcinoma breast. And if you talk about all these factors, the BMI is gone up, the age at first childbirth is constantly going up, age as menarche is going down. So if you calculate the cumulative estrogen exposure over the last decade or so, since these two trials were published, both the risk factors has gone up. And as a result, we have the Globacan data, which is a global cancer data, suggesting that there has been almost 2% increase in the incidence of carcinoma breast. And then we have to talk about the Indian context. So in Indian population, we have obesity is increasing, and we are slowly growing in age. So 20 years ago, we were a relatively younger nation, and 10 years, 15 years down the lane, our average age would go up. And with this average age, the risk of malignancy is going to go up. So from this point also, if we talk about malignancy, it doesn't make sense. The risk-benefit ratio doesn't justify the use of postmenopausal hormonal treatment. Third is osteoporosis. Again, the initial data suggested that with postmenopausal hormonal therapy, you have relatively lower hip fracture, relatively lower vertebral fracture, less data for vertebral fracture, more data for hip fracture. But in the recent year, a different terminology, which is a peak bone mineral density, which occurred which you acquire at the age of 20 to 30, is becoming more important. Yes, you lose your BMD after menopause, but more important part is what was your BMD at the peak. Third point which we need to discuss is risk versus benefit. Yes, it results in fewer fracture. Some benefit of increase in BMD is there, but if you calculate the risk, again, doesn't justify using HRT for reducing the osteoporosis risk. The fourth point, as far as osteoporosis is concerned, availability of better agent. And as far as osteoporosis and bone metabolism is concerned, every 6 months we are having new data, some new big study, new molecule. And if you think about it, you would be hard pressed to find a particular patient in which you cannot use any of the available drug for the osteoporosis. At the same time, without the harms of the postmenopausal hormonal therapy. And as a result, it has downgraded over the year in the recommendation for treatment of osteoporosis. Nowadays, I don't think we see patients in which we would recommend कि भाई आपको osteoporosis के लिए HRT शुरू करना चाहिए. The fourth point is postmenopausal symptoms. Now, this is one particular category in which estrogen does wonders. And even at relatively low dose, about 80 to 85% of the population of the patients have symptomatic benefit as far as postmenopausal hormonal hot flashes and systemic symptoms are concerned. But when you start postmenopausal hormonal replacement therapy for symptoms in the grade 3 or grade 4 kind of a symptoms, you have to ask yourself for how long you are going to give this thing, because in many cases, the symptoms may last to 5-6 years. And again, if you're increasing the duration of these HRT for postmenopausal hormonal symptoms, you are risking the many other harmful effects of the HRT. And if you ask any patient कि भाई आपको ये जो hot flashes होती है बिल्कुल ऐसे गायब हो जाने वाले हैं, but there is a small risk that you will develop a breast cancer. No one is going to say, okay, I am happy with the risk of breast cancer, but I don't want hot flashes. Again, in this particular case, does risk justify symptomatic treatment? And nowadays we are having alternate agents. Yes, initially we had gabapentin and SNRI, SSRIs, but recently Skylight 1, Skylight 2 trials were published. And according to them, the main reason of this hot flashes are neurokinin 3 receptors. And they have developed this neurokinin 3 antagonist, fezolinetant. And if you compare the efficacy, I think at 45 milligram of the dose, 65 to 70% of the patient had complete resolution of the hot flashes. So yes, in this particular subset, estrogen does wonders, but it is just a matter of time before we have better drug which we can utilize for this particular problem. So if we were to summarize all this data, and as I said, I will be presenting a very non-formal kind of a quasi-formal kind of a presentation. So if we were to summarize all of this data and what are the guidelines are, as far as CV outcome is concerned, the Endocrine Society says कि भाई आपको जो है individualize करना है. अगर आपका CV risk बहुत कम आता है, then you can advise कि भाई HRT you can initiate. But at the same time, with the changing phenotype, changing cardiovascular risk profile in India and everywhere else, it remains to be seen how long the same CV risk can be maintained over the next decade. And as far as malignancy is concerned, it is clear no that postmenopausal HRT is adding fire to already burning adding fuel to already burning fire. And the third point, osteoporosis, again, because of better available drug, this is not recommended. Postmenopausal hormonal symptom, especially hot flashes and vasomotor symptoms in that particular subset, especially if debilitating symptoms are present, if the patient's quality of life is so poor that she's not able to perform daily work, she's not able to live a normal life. In that particular subset, yes, HRT is, Endocrine Society says that this particular subset you can use, but that is just a matter of time because before we have better drugs. And if we were to summarize all the data, HRT maybe in decade or so is going to be a thing of past. And I think that is it from my side. Yeah.
Thank you, Dr. Siddharth. Thank you very much for your useful insights and your views of why we should not give HRT. Yes, initially there was a hype of HRT given, but that was quickly demystified, and it said that HRT can be more problematic than causing any benefits. It does give excellent relief of postmenopausal symptoms, but the risk of the other things, as you said, risk of carcinoma breast and risk of coagulopathies are increased. But the problem with HRT is that there are too many contraindications. We should rule out all these contraindications. And one thing that is not always clear is that whether we should screen for cervical cancer or breast cancer before we start HRT. But I think considering that breast cancer has been in the increasing trend, we would definitely at least order a mammogram before starting an HRT, because these days people can have latent breast carcinoma and that can just fully manifest fulminant. Even mammography is the standard of care these days. Even for pap smear, I think before going for HRT, check whether the patient has got a recent mammogram done and pap smear done. And the other thing is that even if you decide and there are no contraindications to give HRT, the maximum set duration for patients fully qualifying the need for HRT just 5 years. Beyond 5 years, the risk of CV diseases actually goes very sky high. So beyond 5 years, it should not be given. I think that's the thing.
As you said that there was a lot of hype when HRT was initiated, and I was doing some research, and during the literature review, I was able to come upon an article. And I had to fish it out from, I think, 1992 or 1994. It was published in a very famous journal, and they said it can reverse aging and whatnot. So things like these come and go, but what the current data suggests, and given the changing phenotype, changing metabolic profile, increasing malignancy risk, at this point of time, there is a very small subset of patients who would actually qualify for HRT. And even for hot flushes and other symptoms, yes, as far as other symptoms are concerned, the dry skin, the muscle aches, and everything else, estrogen remains the best available modality of treatment and best available data. But I think it's just a matter of time. In 5 years or so, we will have some other drugs, and we can stop giving this HRT.
I have a question. So, does this risk of CVD and all, does it apply to the transvaginal route of HRT, or it is for only the transdermal?
Yeah, I mean, there is this argument that when you given anteriorly, the risk of CV risk is increased because the hepatic bypass is not there, and when you give transdermally or transvaginally, the CV risk might be less. But when we talk about the data which is available, as far as non-parenteral route, non-enteral route are concerned, the data is not at all big enough to sort of liberate us to use transdermal or non-enteral routes of administration. Till such time we have such ample data. I mean, in a special subset of patient in which premature ovarian insufficiency is present and you are hard pressed कि भाई अपने पास option ही नहीं है, then it's okay. But for just 1 or 2 symptoms, I don't think that.
Yes.
Yeah.
So the contraindications are too many for HRT. That's the problem.
So just one question. Am I audible?
Yes, please go ahead.
Yeah.
So like when we start for like premature ovarian insufficiency, these HRTs, like, what maximum age you go for that? Like you continue.
So usually I ask कि भाई आपके mother को कितने time पे menopause हुआ था, and that is roughly my target to give HRT.
Okay, so it's very individualized depending on the family history. Okay. Like is that the best way, like, or like is your personal?
See, insofar I'm not aware that there are other recommendations कि भाई आपको कब तक होना चाहिए. I think what Endocrine Society says कि you have to use an individualized approach when you are prescribing hormone replacement therapy. But then again, see. You have to see कि even if the mother had achieved a menopause at the age of 51 and you have a 45-year-old lady who is very obese, who is poorly controlled diabetics and multiple risk factors are concerned, then you have to decide कि that's okay. I don't want to risk cardiovascular mortality just for the sake of the quality of life and maybe bone. I would tackle the bone part from some other perspective, but this is one thing. Cardiovascular mortality is one thing which I don't want to risk. So.
Because gynecologists, I think they are more using these drugs for upper age limits compared to us. Like most of us discontinue in 45 or maybe before 50, but they usually go till 55 whenever they are treating. And if I see those patients, and they say that in their literature up to 55, there is no clear-cut contraindication for that. So there are not much support with the newer generation of E+P combinations and with the new cardioprotective drugs. Which has come in the recent years, because many of the studies they were done in those periods when these drugs were, so that also has modified the risk.
Yeah. So one argument is that in those data, relatively older generation of progesterone was used, enteral route of this thing, estrogen was used, and if you are using transdermal estrogen, if you are using newer generation of progesterone, the cardiovascular mortality which we saw might not be there. But if you see the changing metabolic profile over the decade, and as rightly said that after 2002, it becomes a too hot issue for anyone to handle, and no big study as compared to WHI or other the nurse data has been done with the relatively newer drug. Yes, theoretically we can say that these are third generation progesterone. It won't have as much effect, and we have pharmacological data to support that it doesn't cause coagulopathy, increased thromboembolic risk. But before prescribing, you need big study before you can say, yes, what we are thinking is true.
because with the cancer risk, or maybe this because of medical legal issues, that is why most of the endocrinologists are very reluctant in prescribing. That because they are written very clearly that these are the increased risk, and if somebody gets.
In fact, if you search currently on Google about menopausal hormone replacement therapy, you would got more hits suggesting कि भाई इसके तो खतरे बहुत ज़्यादा है, फायदा तो थोड़ा बहुत होता है, खतरे बहुत ज़्यादा हैं. So that you have to, I mean, and once the patient knows कि भाई there is 2% or 3% or 5% risk of breast malignancy, then no one is going to go for that particular option.
That is why
I mean, push comes to the shove, we have no other option, then you have to start. But
Dr. Sharad Kumar would have argued very differently this topic.
Yeah.
But I think we all missed his point of view because he has a lot of experience and a lot of data. So I think we could have have a more wider and diverse discussion. But I think we all, including the panelists, are in the same side, like more towards no side compared to the yes side. So we lack. So anybody who want to differ this point of view?
I think most endos don't prefer.
So thank you, Dr. Siddharth. With this, I think we are ending this session, and I thank you for very wonderful talk. And so with this, we have finished the agenda of Hall A, reproductive endocrinology, and it was a very wonderful day. And we started with the most important topic of hypoactive sexual desire, and that was mainly focused on women, and followed by Dr. Pramila Kalra discussed about transgender and how to diagnose that, and followed by gender affirmative hormonal therapies. And after that, Dr. Sambit Das discussed androgen deficient in aging population, followed by Dr. Viplov discussed about ovulation induction. And Dr. Kalpana discussed the recent advancement in PCOS, and with Saqib and Anshul beautifully discussing the metformin and GDM debate. Finally, Dr. Siddharth had a very good data and discussion and very practical point of view on HRT in post-menopausal women. So with this, we are ending this. We thank you all for joining this. And tomorrow will be again a very busy day, and we'll be having Bone Day, and both Hall A and B, and we'll join you again tomorrow at 5 p.m. in the evening. So thank you all for joining this.
Thank you, all the speakers, all the delegates who have joined in, giving their time. And just to say again, you have to join on all the 7 days for having the 9 credit points of MCI. We have still one more talk on the finances, the stock market going on in Hall B. So those interested can join in there. Stay tuned for more lectures. Tomorrow would be a bone day followed by thyroid, and then the last weekend 2 days would be for diabetes. Thank you everyone. Good night. Tech team, we can end in Hall A.
Sir.